with our right hand, all right? With our right hand, with the fingers only. Now, the small finger will be 1. The ring finger will be 2. So, those 2 fingers represent 2. When you add the middle finger, that is 3. When you add the index finger, that is 4. When you add the thumb, that becomes 5. So, guys, this is not 5, this is 5, all right? This is not 5, this is 5, all right? So we'll be counting with the right hand only. Now, with the person you chose, or the person who chose you, I want you to stand back to back, facing opposite directions. Back to back, facing opposite directions. I want you to think of any number, hands down, hands down. Think of any number between 1 and 5. The MC will count down 3, 2, 1. On 1, I want you to turn and face your partner and put up any number of fingers. The first person between the two of you to do the summation of both hands. For example, my hand and my imaginary friend's hand, if the person did a 4 and I did a 5, the total is 9. The first person to shout a 9 wins and is the smarter one for that duo. All right? So let's try. This is just a trial, Think of a number in your head between 1 and 5 using the right hand fingers. We'll count them. Don't show a partner, don't show a neighbor, don't show a competitor. Think of any number. On 3, 2, 1. Turn. All right, so as I said, the first person to shout the summation of both hands is the winner, all right? The first person to shout the summation of both hands. So now we know how it will go. Let's now start the game. Sindio? Let's now start. So back to back one more time, back to back. Think of any number between 1 and 5. May the smarter one win. On 3, 2, 1. All right. Find somebody else. Find another partner. Leave that one alone. Find another partner. Leave that one alone. Find another partner. If you didn't win, now at least try and win this one. We are good to go? All right. Think of a number in your head between 1 and 5. On 3, 2, 2.5, 1. All right, find the last person. Find somebody else, the last person. Find the last person. As we continue, find the last person for the last round. Again, standing back to back. Think of a number in your head between 1 and 5. All right, let's do this in 3, 2, 1. You may have your seats. Thank you so much. You may take your seats. Thank you so much. And welcome to today's session, the Desip Family Planning Learning Conference. I want now to invite the official MC for the day, Kamande. Take the stage, please.
Good morning. Thank you, Edu, for that nice icebreaker. And thank you, everybody, for showing up on time. And we are going to have our first session for today. The first session for today is a panel discussion moderated by Dr. Geoffrey Okumu from Options. And the discussion is going to focus on total market approach in family planning, ventilating on why we need access in all sectors, whether public, private, faith, and why we need to facilitate access to everybody, those who have, those who do not have, and those who are abled differently. Dr. Okumu, please.
Amjambo. What happened? The cocktail took some of us away, or what happened? So to start us off for the morning panel, and this is the first one, I'm going to invite Kenneth Macharia, who's the regional director for options. He's going to give us an overview of the private sector opportunities within the total market approach. So that is going to lay the ground before I invite the main panel after that to take us into the discussion. Thank you.
Thank you, Jeffrey. Good morning, everyone. This is a bit of a strange one because I thought there would be a podium to actually stand on and give this presentation. So let me first start off by introducing myself. My name is Kenneth Macharia, and I'm the regional director for Options. Options is a global consultancy with a very strong presence in Africa, and particularly in East and Southern Africa. We are based here in Nairobi with a very big office. First and foremost, I'd like to acknowledge PS Kenya for organizing this event. I'd like to acknowledge PS Kenya for organizing this event, and Dr. Margaret Jenga, their CEO. FCDO, represented here by Lawrence Matenjo, cannot see Akacho today. Ministry of Health representatives and colleagues, ladies and gentlemen. I'm really pleased to be here with you. I was here yesterday. We're very exciting start to a conference of this nature. So as I said, Options has been around for 30 years. Global health consultancy focused on health system strengthening in Africa and Asia. In Kenya, we've been here for 20 years. 20 years working in over 26 counties. So we built really good relationships with the Ministry of Health, Council of Governors who are here yesterday, as well as other partners, in particular PSK, who we recently signed an MOU with. Since 2019, we've been supporting the Ministry of Health, particularly around ensuring a conducive policy and regulatory environment for effective private sector engagement in the commodity market. And this is important because this speaks to the topic that we're going to be discussing today, which is around total market approach in family planning. As a result, this work led to the total market approach for the family planning strategy 2020 to 2025, which we supported the Ministry of Health to develop. And what is it focused on? Better quality, regulation and compliance, diversified family planning supply, increased number of family planning players operating in a segmented market, and improved stewardship of the family planning market. Now, what is TMA and why is it important? I just felt that I think as we talk about this topic, because its origins come from the private sector, particularly looking at marketing, and particularly companies like Coca-Cola, Walmart, and others, who really understood the fact that not one size does not fit all. And I think as we were having conversations yesterday, this particular point came true, or rather it was really emphasized by a lot of the speakers, particularly looking at issues of culture, issues of religion, disparities across different regions. For example, in Kenya, the northern part of Kenya, and getting access to different products, family planning products becomes an issue. The issues of facilities and mothers actually going to facilities to deliver became a real issue that was highlighted yesterday by several speakers, as well as the quality of service. So why are we looking at total market approach? So this is really about the public and private players coordinating and looking at ways in which they can provide more access to products in the marketplace, but giving choice to those consumers, and particularly mothers and women who are looking for those products, but as well as men, because I believe this is an area that is being rolled out at the moment. FCDO mentioned that every £1 investment leads to 4 pounds of savings. So this brings up the component of financing. We do not have enough resources to go around. So how can we leverage other players in the marketplace to be able to bring these products to market, but also reduce the cost of access for those people who really need these products? I think it was also highlighted that we are 7 years to the SDG 2030. So we don't have a lot of time. So how do we accelerate the approach towards ensuring everybody has the right products, that they can access them? For those who are vulnerable and unable to access these products, how do they get access to them and have the choice to make that, to access that product? I think it was also highlighted that the bottom-up economic transformation agenda by the Kenya Kwanza government is a key, it's a key pillar to that. So how do we align with that, and how do we ensure that we are supporting that particular agenda? So the goal of this approach is around access for the poor and marginalized groups, sustainability for provision of FP services through effective financing, enhancing choice of products and points of access. So what are the considerations I'd like to leave you with today? Really, we need to encourage local manufacturers. And this is really one of the components of encouraging private sector to be involved in this, and ensuring that they're involved in the long term. So what does the government need to put in place? So these are policies, the regulatory environment, but also thinking about the tax regime in the marketplace to ensure that this is accessible. Financing mechanisms become very key. As we know, the fiscal space is rather difficult at the moment, and we need to figure out how can we all pull together towards ensuring that these commodities are accessible and affordable to those that need that. The regulatory environment needs to be streamlined to just make sure that it's predictable, so that anyone who wants to come and provide products, wants to participate in this space, can actually do so in a very transparent manner and be encouraged to do that. And so doing that on the background of ensuring that there's safety and oversight when we're operating this marketplace. Lastly, to just talk about data. So we can't operate without data. We need to understand the marketplace. So where is this data and who has access to it? I think it's extremely important that we ensure that everybody has access to this data, and in a what do you call it, in a responsible manner, right? That leads to ensuring that the products are accessible, that we understand the costs, determinants of these commodities, and ensure also we understand the connection with the communities and the users of these products, so that we know that there's a feedback mechanism for them to actually say how the products are working for them. I think there's a big discussion around adverse effects, for example. How does that come into play when we're talking about safety of the people using these products? So I want to stop there. I want to thank you for this opportunity. Pass it over to Jeffrey. Thank you for listening to me. Thank you.
Thank you, Kenneth, for that very good presentation. We'll move on then to invite the panelists for today, and I want to start with Daniel Mumbia, Minister of Health. He's the task force chair. Is he here? Yes, join me in welcoming him onto the podium. Secondly, I want to invite Sylvia Wamu, is Chief of Party for the Private Sector Engagement Program that is led by PSK. And then Kenneth Macharia again, join us on the podium. And then Willie Somondi is the Institutional Health Supply Partnership Manager, Sub-Saharan Africa. Is he here? Yes. And then Michael Mugoma from the Pharmaceutical Society of Kenya. And then Miriam Modoni from KEMSA. Is she here? Excellent. Yes, so thank you, gentlemen. So we'll start off with the Minister of Health. Just tell us what is. Can you get some assistance here? So Daniel Mombia, can you just tell us what is TMA and why is it important?
Yeah, good morning, everyone. Nice to be again on this panelist today morning. So basically, total market approach, what you are bringing out in our strategy as the ministry is a coordinated means of ensuring that those who are willing to get free products from the parties and those who are able to pay access this in private facilities, and of course, even in social franchise, are able to access these commodities with the aim of being able to maximize the access bit of it, ensuring there's equity and also sustainability. So being able to create a platform that all these clans or Kenyans are able to get the commodities from across the three market segments. So just ensuring that the public sector market segment, the private and non-private are accessible and are able to provide FP services over time.
Thank you. We are aware that the Ministry of Health launched the strategy in 2021, but at the same time, at that same period, they also made commitments to FP 2030. And one of the commitments they made was to increase the CPR from 58 to 64, and then also reduce the unmet need from 14% to 10%. And then made a commitment that by 2026, they'll be able to cover 100% of the financing for commodities. How are you, in the process of operationalizing this strategy, how are you ensuring that you're able to beat those targets?
Sure. So across all these 8 strategies, particularly number 1 around MCPR and met need, and of course the last number 8 in terms of domestic financing, are in line as one way of achieving this commitment. TMA strategy is one of the house. Looking at a particular strategy that talks about access to the services, ensuring that last mile access. So TMA strategy is coming in handy in terms of ensuring or providing a mechanism across all the service delivery model in terms of what needs to be in place to ensure that Kenyans are able to access commodities. Because looking at what the recent 2022 KDHS a survey result is placing the public sector 62% in terms of access for FP commodities, the private sector around 33%. So this provides, this presents a case that there's still a big population that are able to access commodities in public sector. But how can we be able to strengthen the private sector? Because in most cases, as presented yesterday by the counties, like Mombasa, you heard they're having more private facilities. Then how are we able to define these service delivery models and come up with a mechanism to ensure that Kenyans are able to access those who are not able to pay, they can get from public facilities. But those who are willing to pay, can they be able to access the services in all these private facilities? And of course, those in informal settlements, are they able to access even these commodities? And so that one presents as a strategy in terms of that, to ensure that once we have defined this, and we have done a roadmap to ensure how can we be able to reach out, how can we come up with a framework to ensure that Kenyans are able to access this commodity across these market segments. By accessing these commodities, then we're able to see an increase in our MCPR, a reduction in unmet needs, and of course, with the TMA, we're also presenting a case for financing, domestic financing. We know it has been increasing over time, but we are seeing a decline in terms of donor financing, even what you are getting from the FCDOs, so a bit of a decline. So how do we be able to pick this up? And TMA strategy is one of the ways we are presenting to the policymakers that this is how we are defining our market segments, and this is why we need support, because of more Kenyans needing access to free services for FP. Thank you.
Thank you. Sylvia, you are aware that the main purpose for launching the TMA strategy for FP is to harness the opportunities within the private sector. And as you've heard, the Minister of Health is relying on the private sector to enable it meet its targets, the targets that they've set, and even to reduce the burden so that the financing, they're able to afford the cost of commodities that is expected of them. Now you work with the private sector. Can you please describe the FP market within the private sector?
Thank you very much, Dr. Okumu. And as we've heard, my name is Sylvia Wamuhu, and I am the Chief of Party for the USAID Private Sector Engagement Program and the immediate former director for Desip. So I'm extremely excited to see all of you here in this great learning platform. So we know that the family planning market is growing in Kenya, and that is evidenced by the KDHS. You've heard that we have really grown as a country. In 1988, we were at 18%. Now we are at 57% in terms of uptake of modern contraceptives that are taken up by married women. And we know that all these women we are talking about, if the uptake is increasing, that means that more women are taking up contraceptives. So where are they taking these contraceptives from? It means that the public and the private sector are contributing. So the private sector becomes extremely important and critical in ensuring that women are accessing family planning services. And sometimes I always ask myself, because it is some people, or there's this school of thought that the public sector should be providing essential commodities. But just think about a situation whereby all of us were accessing FP commodities or any other essential commodities from the public sector. Can you imagine the overburdening of the public sector? Can you imagine the overcrowding? Can you imagine if we ran out of stocks, would not have any fallback? If at all there was a delay, even let's just take an example of something that has happened before. If there was a strike of the doctors, then what would be happening? So that just emphasizes the critical role that the private sector plays in providing essential services, family planning commodities in the Kenyan market. That said, so what is the contribution of the private sector? We know that the private sector, and I know he has spoken about it, it contributes about 40% of all the commodities that are accessed by women in Kenya. The private sector supplies about 40% to them. But at the same time, we know that all these commodities do not necessarily originate from the private sector. But we have some success stories. And when we look at the oral contraceptives, about 65% is actually accessed from the private sector. We have the social marketing that plays a critical role. 60% is actually from social marketing, and 5% is from the fully commercial market. So you can see it can work. The private sector can actually play a critical role. But when you look at the long-term methods, we still have a problem because the contribution there is not much. About 22% is actually accessed from private, injections, that's 7%, IUCDs 15%. But at the same time, I'm saying, what is the original source of these commodities? Most likely for long-term methods, public sector. Where does the public sector get the commodities from? Government resources and development partners' resources. And it is not sustainable. So what I'm trying to say is that it is possible to change the narrative. We have seen that the private sector plays a critical role. If we supply 65% overseas through the private sector, then it is possible for us to do that for long-term methods. And it is, Ken just told us what we need to do. We need to think about what can local manufacturers do? What public-private collaborations do we need to come up with to ensure that this works? So I'll stop there for now, just to hear what other people have to say about it.
Thank you, Sylvia. And you brought up an important aspect in that the private sector still relies on public sector commodities. And at the same time, we are telling the public sector to finance 100% of its budget on commodities. While at the same time, the private sector is also relying on that, and we need to find a way of breaking that chain so that we reduce the burden on the public sector. Now, coming to Willis, you are part of the private sector, but manufacturing. So how do you fit into the TMA strategy, and how do you how can you be able to help the private sector be able to access commodities at a cost that is affordable to them? Thank you.
Thank you very much, Dr. Kumo. I would just like to structure my thoughts so that we are all aligned. One is that we have a target by 2026 to shift so that the government picks up 100% procurement of contraceptives in the public sector. So that's 2 years from now. And by doing so, it means that we have to open up. So there is this pyramid that we always talk about in terms of commodity. The bottom of the pyramid is the free commodities that the government procures. For the last almost 7-8 years, I've been in procurement for a long time. For the first time last year is when I consistently saw the government procure direct financing from the ministry. So it means a positive change. But the bottom of the pyramid still carries a lot of weight on top. So for us to change this situation, we need to distort the pyramid so that now it's no longer a pyramid. Because then in the middle we have the social marketing organizations, and on top is the fully commercial guys. They need space to operate. We are not giving them space. Yet in 2 years we expect that the government finances their own to the public facilities, and private sector is able to address the other segments. Now this is what it means. I'll take for example the implant. So the current situation is that there is no supply chain system that can serve the private sector. So if a woman needs implant in a private sector facility, she's not able to purchase. So already that's a problem. We cannot achieve the 2026 target. Two, even if we had the implant, the prices are quite high, okay? And there is no even commodity that targets the private sector. You know, that unique commodity. Otherwise, then everybody goes to the public sector and gets those implants, including the big hospitals and the small facilities. So we need to change that. So in short, there is lack of incentive in the private. Why should I buy commodities that are not being, why should I buy and then nobody is procuring them or accessing them? And two, the distortion that 40% of implants contribute 40% of the method mix, yet they are not even in the private sector. So those distortions, because of lack of incentive, and two, because of subsidies, there is too much subsidy on the public sector, we need to address. So I'm a manufacturer, so I speak on behalf of manufacturers. We need to create a rational, balanced, and sustainable market. We need to get out of the pyramid that we have been talking about. Then two, the S-curve. The counties that have been always marginalized, Marsabit and all those counties, nobody is addressing them. Nobody is sending contraceptives on those sides. So eventually, we have a situation where we have all the method mix in these big cities, and then there is nothing on the other side. So that's the second thing we need to address, the imbalance in terms of regional distribution. And so what are the solutions? Domestic financing has been mentioned, because if to me, I have a product, and the private sector is able to purchase it, but then nobody is able to buy it because of the cost. Jadel is 1,000, for example. Nobody will buy it. But if the health insurance comes, or whichever model of financing, that's good, because everybody, and we have these meetings. We have the insurance discussions which are going on right now, and many other alternative distribution mechanisms that we hope that by 2026 will be okay. So private sector capacity, even if we introduce that implant, that's my line of thought, implant, but the other methods, to the private sector, the pharmacists, the pharmtechs cannot still administer, because the policies are not conducive, they are not there. So we need to address issues of policy, we need to address issues of training and capacity, and then finally, market segmentation. I will introduce a product, I need to differentiate it, but I need to be guaranteed that this product and all my investment will be recovered. So Bayer, as a company, now let's talking about what we have done as a company. One is we no longer accept any partnership. So we used to give a lot of donations, We said we need to develop a criteria. What does it mean to reach that target of 2026? Whoever comes to partner with us must introduce a very sustainable model. Two, it has to be a self-resilient system, the system that can stand, the health sector, turmoils. Three, donor independence. 4, it has to be a scalable intervention so that we don't introduce new concepts every year. And finally, freedom of choice must be guaranteed. Whether it's my product or not, there has to be that freedom of choice from the donor independence, from service provider, and also from the method mix. So manufacturers are committed, but then it needs everybody. That's what I'm trying to say. Everybody must play their role. The government, the PPB, KEMSA, MOH in policy, manufacturers, and also the service providers. I think I've given a 360.
Thank you, Willis. That was quite comprehensive. But I'll come back to you to tell us how you're channeling this discussion within the Ministry of Health to ensure that is adapted. But I'll come to Kenneth. Having listened to the discussion from the contribution from the Ministry of Health, from Sylvia and from Willis from the private sector, what do you see as innovations that can be considered for this sector?
So thank you for those presentations. I've just taken note of 2 points, sustainability and freedom of choice. I think as the market grows and we start looking at total market approach, the forces of supply and demand come into play. And it speaks to what Willis is saying, is that how do I make the business case of bringing a product if I'm not really clear about the market that I'm actually putting this product into? What is the price sensitivity of the consumer? And actually, what are they willing or able to pay? I think that's the other thing. But it's important to look at it in 2 ways. I think there's a real need for the public sector to provide those services, because there are people who are unable to pay for those services. So we need to ensure that those people are catered for as a start. So the group that we're talking about here is the people who have the spending power and the ability to access these different products in different places. So what is the case here? How do we ensure that those people who have the ability to pay can actually access those products without necessarily overburdening the public sector? Because I think that is really important. But more importantly is also how to create a space for the private sector to come into it, having a lot more clarity as to how do they actually get their product into the country, but also how they administer it. I think that speaks to the whole regulatory environment that we were speaking to earlier. But I think in terms of innovation, I think the issue of data is really at the core of it. Right now, the government is looking at digitizing health, and it's because of that realization that without a good understanding of the public, the people that you're actually providing the services to, it becomes very difficult to even talk about segmentation, because then segmentation becomes very nuanced without necessarily having that economic view, or rather, not having the scale to make the economic sense to actually make the investment for some of those areas. So I think data and how we harness the data, how we share the data across the board, I think is really, really key. And so I think in terms of innovation, bringing in new approaches to, one, collecting the data, but analyzing that data. I believe the system that we currently use, I mean, a lot of the data is historical. And so you find that at the facility level, for example, people want to make decisions, but they don't have the real-time data to actually make those decisions at that point. And so going into that space and actually investing in data systems that allow us to harness the data quickly, and so that we're able to understand the needs, and really speaking to this whole point about segmentation, then how do you segment? You would need the data to do that, and meaningful data at scale.
Thank you, Kenneth. Let me come to Michael. Michael represents a membership organization, Pharmaceutical Society of Kenya. And you have members who are both in the private and public sector. What do you see as the role of the Pharmaceutical Society of Kenya in advancing the agenda on total market?
Thank you so much. Again, the society is an umbrella organization. It's a professional association where the membership is pharmacists. So as regards TMA, I want to say, one, that we are enabling our pharmacists, one, to provide family planning services so that they are not just dispensers or vendors. They are actually service providers. What has happened over the years is that the society has worked together with other partners, including the Ministry of Health, and we've come up with a training package for pharmacists and pharmaceutical technologists to provide quality family planning services, including injectable centers. And I just want to report this is something that is going on very well. And going back again to what my colleagues have talked about, market segmentation. We realize again, community pharmacies play a very unique role. One, they are in the middle of communities. They're very, very convenient to approach. They are easy in terms of being able to communicate with the pharmacists behind the counter. And with technology in urban areas again, telepharmacy again would assist towards achieving some of the TMA objectives. So again here, we are looking at not just any pharmacists participating, because the wider goal again is to achieve what has been talked about, the FP 2030 goals. So the efficiency of getting the right people on board, meaning there's a criteria of people, criteria of pharmacists that we want to engage. Two, that once you are trained and certified, then you are obligated to report back to the MOH, through the DHS. So which again contributes to data harnessing, data mining, which will contribute again to better decision making. So we look at it as a service delivery model for TMA, community pharmacies, and that too, what you mentioned earlier, the mix that we have in the society. We have people from private and we have those from public. So again, there is sort of like a public-private partnership already existing, which now improves how we engage with TMA. Thank you.
And still with you, Michael, one of the things that is being advocated within the TMA strategies and which other speakers have talked about, is limiting the supply of commodities to the private sector. And I know most of your members are within the private sector. How are you preparing, or how are you engaging with the manufacturing sector or the commercial sector to be able to negotiate and get products at an affordable price?
I think, remember again that people in the private sector think about profits. So they can't just get into this business if they don't see the profits. But again, it's important to mention something that was earlier mentioned, that there's this segment in society that are willing to pay a fee. So that is something that we put together. And even as we engage the membership of the society, we usually and continually bring in manufacturers and suppliers so that they see the benefit of engaging the membership of the society. We are also, we have membership, we have members, KEMSA members, MOH. So this is a conversation that, for us, we look at it as advantageous in the sense that we have all the players in the society, so that when we put out our case, it is something that they can listen. I know this is a slow process. When I talk about pharmacists being able to provide these family planning services, including injectable contraceptive, we're probably 2 years into it. So we are still collecting data and looking at all the other opportunities and gaps that can be filled to ensure that we are able to access affordable products and contribute to this.
Still on you, because I know the program of training pharmacists to be able to provide the commodities has been very, very, very useful. And I'm wondering what coverage do you have? Because I know the unmet need is high in the rural areas than in the urban areas. So what is your current coverage of pharmacists who have been trained under that program?
Yeah, so we have about 250 pharmacists who have been trained so far. But we also have about 200 pharmaceutical technologists. So these are two different cadres. and this is spread out through the country. This is a very small number. And I want to say again, most of them would be distributed among the urban areas or the urban towns. However, this is work in progress. We are still looking for support. Remember, training as well as monitoring and evaluation is not a very cheap process. But we believe we've already had conversation with a few partners going into 2024. We're going to have at least 4 cohorts being trained. And maybe at this point, I want to say again, the introduction of implants to be provided at community pharmacy is an ongoing conversation. And we are hoping that by the end of 2024, we should be able to get a training package and maybe 1 or 2 cohorts trained out there.
Excellent. Kemsa, the conversation is about you. How are you plugged into this discussion on TMA, and what do you see as the opportunities?
Good morning. As for KEMSA, we now looking at expanding our supply base. We are now supplying to the private sector, the social marketing sector. We've partnered with Maristops Kenya in terms of the social marketing sector. For the private facility, through approval from the DRMH, we are able to supply to private sector because we realize that there are counties that hugely rely on private sectors. So we've been able to grow our supply base really.
So in other words, you'd be sourcing the commodities and then selling them to the private sector at a subsidized rate?
For now, no. We rely on the products that are given to us by the UNFPA. So we supply to them as an extension of the public sector, public facilities. So we give them to them and then they report back to the ministry.
So as KEMSA, you are the single procurer of government commodities. How will you know that TMA is having an impact? Rather, the private sector is fully involved in the provision of FP commodities. How will that reflect on your side?
Mostly we'll focus on data, the data they give back to us. So that one will be used in terms of quantification and just data to just harness the data and knowing what is happening in that sector. And then largely through the help of the DRMH, we're able to identify the main private facilities that supply these commodities. In case of Mombasa County, the county looks at the private facilities that are hugely involved, report to the DRMH, then the DRMH gives us a go-ahead in terms of realizing what is being used in those private facilities, sorry.
Thank you, Miriam. Coming back to Daniel, I know as part of the implementation of the TMA strategy, a task force was formed. And so can you tell us something about that and how you're operationalizing the TMA strategy?
Thank you. Of course, because many people are struggling actually to understand TMA, but that one we have observed in the country. But try to implement TMA, the ministry, so it's aware that we form a task force. And I'm glad to say that all these people, all these panelists here are, and I think we have engaged in a number of sessions. We are able to come up with a service delivery. We are able to come up with a roadmap. So within the roadmap, we're able to define some of the milestones that should be done to be able to actualize TMA in the country. And one of them, as we are trying to say, how she tries to present the case for the lacks, the most lacks in the public sector. So we have been able to first say that, can we come up with a checklist and a service delivery framework to be able to understand a case for each market segment, the way you were saying. So that one, we are in the process. And we thank the task force members represented here for the support in terms of coming up with that service delivery framework. I know it's work in progress, has not been done, but once we have that defined, we shall be able to know how then do we cater for the needs of each of these market segments. So that one is helping us to come up with comprehensive service delivery models for all these three segments, and to be able even to see how do you standardize even access in terms of can they, we want to understand why can they be able maybe to get implants that these are the lacks, then how, what is the role, how can you be able to help as a ministry? Yes.
And then, thank you so much.
And just maybe to add in terms of what she was presenting as a case for digitization. Of course, you know, our ministry, of course, is doing milestones around digitization as a key priority for the current administration. So for our hand as Ministry of Health, we have been able to come up with the interoperability framework. We don't want to kill the systems within the private sector. So with this framework, as Ngoma said, we're able to get what the private pharmacies are offering, what have been trained. But as we define this service delivery framework, we shall be able to see what systems are you using for capturing or managing FP commodities. Then you can be able to share our APIs and be able to get all those information into the one central digitized system, our EMR, which we are calling the FAKE, and also the smart primary care networks that we are developing across the country. Yes, thank you.
Thank you so much. Now, Willis, you did mention a number of issues. Understand the market segment, the need to do the
So that's one thing. So I'm an advocate. I need to make sure the TMA technical team understands that process. For KEMSA, and this is a very general conversation, it happens in all countries. Their mandate does not allow them to distribute to private sector. Already that's an issue. Because if today I want to tell them these particular implants must go to the private sector, it's not even possible. The procurement guys are telling me it's not possible. We need to, until the mandate is changed. So now another issue is that, and then for you, if I bring for you this contracept, have you trained all your guys? We have a huge workforce in the private sector, healthcare providers. Are you ready to do that in terms of quality? Who will supervise them? How will they report? So you see, that's a discussion that happens in the TMA. And then finally, the issue of you know, issues of money come into play. So we have had cases. Morocco, I was part of the team. We introduced the anticoagulant, Cogenet. The government said we need data. We said, look, we will build a center of excellence. All the hemophilia patients got there. We will profile, we will create a database for the country. And for the first 5 years, you will buy at this amount, but guarantee us, you know, a price volume guarantee. Guarantee that you will buy this quantity of commodities and we will manufacture and deliver, whether you pay or not. But then we have a database of almost 80% hemophilia patients. And the same has happened to Coartem. When I go to the village nowadays, I can get Coartem very cheap, below $1. I can get the other, and I can get a Coartem at $10. It works in Kenya. Our product called Microgynon, it's in the free market, it's in the highly subsidized in the social marketing organization. We give them in hundreds. In the government, we pack it in 3, and we have the premium one that we sell at $3. So it works, but it's a lot of work for us manufacturers. So what I'm saying is this, we want every one of us to play a role, and then TMA will work very well. I'm a believer of TMA.
Thank you, and that's a good rallying call. Sylvia, you are the single largest program supporting the private sector. And you've had the conversations that are going on. And so as your program, what do you see, what opportunities do you see for you to be able to step in and support?
So thank you, Dr. Okumu. The first thing that I want to say is that the demand is there, but it is not there in isolation. It is there if other things have to be put in shape. We have to really shape this market and make it healthy. Then we have to reorganize the private sector. And why I say the demand is there, if 75% of the facilities in Mombasa are private, can you imagine? 2026, the development partners are not providing free commodities. So the market is right there, 75% of the health facilities in Mombasa just waiting to buy. But at the same time, for this to happen, and this has been said, the enabling environment must be right, and the policies have to be right. Because we've heard that it is not that the private sector or the local or the manufacturers are not willing to provide, but where is market? If the public sector is providing these commodities, then who is willing to put his own shilling there in terms of, supplying the private sector? So the demand is there, but we need to work on the environment. But let us take advantage of all this. If we have the TMA strategy today, that is a very good first step. And I think we have a very strong task force that is really looking at how the private sector can be involved. I think for the very first time, we have manufacturers in that room. We have the distributors, the suppliers. That in itself is a big opportunity. So that as we're talking about really ensuring that the policies are being operationalized, then we have a voice as private sector. Private sector is the powerhouse for innovations. I think we have these products that we have the pills, we have the injectables, we have the implants. What else can we bring in the market? Because as we're talking about the private sector, then we have to make sure we are more vibrant and we are evolving over time. I think we can be innovative in terms of the products, in terms of ensuring convenience, in terms of just ensuring that technology is being utilized. Today, the consumer is very sophisticated. They want convenience. How do we utilize all those opportunities that we are there today? And then I will not emphasize on the importance of data. How do we utilize this data as private sector to ensure that we understand the market, even as we're talking about the Digital Health Act? What opportunities does that act present to us so that we can understand what's happening at the health facility level? And quality. I know a lot of consumers really think about, private sector and quality. Is it, up to date? So we have to really invest in capacity building. We have to invest in innovations like the mark of quality. If I go to that facility, I know they're offering high quality services because they are this level of facility. And we have to work together, whether we are starting from the level of manufacturers, all implementing partners, private sector, I know that can be done. And I know we mentioned about access to affordability of these services. Today, if you talk to the private payers, they really don't like covering family planning because they say, you are sure if you're a woman of reproductive age, you are going to use, family planning. But what models can we come up with and say that family planning is very important, all the women need it, affordability might be an issue, and therefore we need to come up with models that are going to ensure affordability through the private sector. Is it that we are going to come up with hybrid sort of models, that we are going to work with SHI today and see what the models will come up with? Is it that the local manufacturers maybe can work out something with the insurance payers? So that is one of the things that we need to do. Is it that we need to, because the insurance companies tell us, show us the business and we'll cover. But again, we can also say, your innovators actually design and innovate that, market, because we can see these discussions are happening today. And what I mentioned earlier, the public-private collaborations, that are very, very critical in ensuring that we move this agenda forward, and especially in the private sector. We are talking about the Facility Improvement Fund. It means that the facilities will have funds. What collaborations can we have with those facilities in the public sector to actually have some sort of innovations with the private sector? I know it is in terms of maybe provision of products. We know that a lot can happen there. So there are very many opportunities that are there. But at the same time, as you're saying, let's also be loud about this. Let the consumers know that they can access family planning, because, as I said, we are innovators. Let them know that they can access at a certain price, so that they're not always having that perception that family planning methods or commodities are very expensive, you have to buy them. But at the end of the day, we know that today we're talking about local manufacturing. Are there opportunities for us to produce or to manufacture family planning commodities in Kenya? It is possible. That is what we're talking about. And we can even think about technology transfer. We can think about how we can embed this in our institutions, so that as a country we continue to grow and not really rely on imports. So I think those are that are there for the private sector. Thank you.
Thank you. At a recent meeting, it was mentioned that Kenya, Nigeria, I think, and Ghana are the front runners in local manufacturing. So I think there's potential there. And I think one of the challenges for the manufacturing sector, which maybe Willis can speak to, is the issue around WHO pre-qualification. That is a big barrier for the private sector to be able to ensure that they get the product into the market. I don't know, Willis, if you want to say something about that before I come to
Yeah, absolutely. So for the implants, there are only 2 that are WHO pre-qualified globally. We cannot serve the market. It's just too much. Even if our factories for implants, we only close them for 2 weeks in a year. So you can imagine. So they run throughout here, only for maintenance. For the pills, in fact, what we do is a cost recovery model. We don't make any profit from the combined contraceptives that we manufacture. But it's too much, we can still not. It's because the process of WHO pre-qualification can take even 3 years. And so it's tedious. Not many people who are businessmen want to invest. 2, the issue of registrations. In Rwanda, you can register a company. Kenya, Nigeria, we spend a considerable number of time. It's tedious. So it's a big issue. And then finally, there was one issue that has slipped, and it was quite important, but let me just keep it. I thought I wanted to mention it, but it's okay.
We'll come back when you remember. Michael, just talk about quality assurance. How do you ensure that your membership, who have been trained and are providing service, how do you ensure that the quality is actually guaranteed, the quality of service? Because we know that that's one of the challenges, particularly if you have a large number of people trained and you don't have a mechanism or a framework for supervision, then you find that at times people tend to take shortcuts, and eventually then you have issues around the quality of care.
Yeah, so quality, again, is something that is central to the whole training and recruitment, yeah? So to ensure that we do background checks among the pharmacists, and that, 2, they have facilities that can consistently and continually provide these family planning services. Over and above that, once they have been trained, then we do follow-ups, and we're actually in the process of coming up with, again, an approved MOH monitoring and evaluation tool. Upon completion of training, they get a certificate, and they have to go through certain procedures and do them proficiently before they are fully certified as FP service providers. But this is not to forget that as we do this, we also have other partners coming in. Like I mentioned earlier, in 2024, we hope to bring in implants. We are currently engaged in a project called Optimizing the Pharmacy Channel, and we're going to the phase 2 of that. So part of that is, again, engaging those that have been trained and seeing that, are they still doing the same thing consistently and accurately to ensure that there's quality. And two, we work very, very closely with the Pharmacy and Poisons Board, our regulator, to ensure that the facilities and the persons that are providing these services are qualified and are competent. PSK continually provides CPDs, continuous professional development, and family planning has been quite core in our CPDs, just to ensure that even those that are not trained but are still providing these commodities, for example, the emergency contraceptive pill, that is something that is continuously just being dispensed and sold. But we've seen a change in attitude towards that among the pharmacies who are now dispensing, because they now understand that they need to be service providers rather than just dispensers or vendors. So that provides a very critical element in the quality of FP service provision.
Thank you. I think that has been quite comprehensive. I'll give each one of you a minute or two just to give just closing remarks, and then we'll invite some questions from the audience. Thank you. So you can start with Miriam.
Okay, thank you so much. For my closing remarks, I'll really emphasize on data so that we can really harness this data in terms of quantification and resupply, because this is what, as KEMSA, we are using to resupply to the private sector, to the public sector, and even to the social marketing sector. Thank you.
Thank you. Thank you very much. Kenneth?
Yeah, my closing remarks were really about, it really hits me that we've talked about everything, but not really about the user themselves. And I think as we look at the total market approach, we also have to understand what is the feedback loop, right? Where does the consumer come into this? And what role do they actually have to play? What mechanisms do we have in place to ensure that their voice is actually coming through? And that will speak to some of the issues we talk about quality, because quality, then who are you talking to? You're talking to the same people, but the consumer is not necessarily in that conversation in terms of what that actually means to them, what it meant, and that sort of thing. And that then goes back to everything we've spoken about. Just to conclude, obviously 2026 is not very far. There's a lot that we need to do. We need to really accelerate everything that we're doing. If the issues of data would really help to get everybody on board. So I think we really need to have all hands on deck for this to really work. Thank you.
Thank you, Kenneth. I'll skip Daniel and then come to Daniel. Will give the overall when we complete. Maybe Sylvia.
Okay. So I think what I have to say is that TM can work. I think there's a lot of investment that has been made so far. And now that we have the strategy, the challenge is to the private sector, the manufacturers, to come up with a model that demonstrates that it can work. Why can't we come up with a model whereby, as we are implementing all this, I know now we are testing the model but what is this that we can come up with and show that maybe there's a small subsidy, but we are enabling affordability by the private sector and even the consumer, so that as we can move along together.
Thank you, Sylvia. Willis.
For me, it's just about innovation, and innovation has to come in, because if you tell sector, it's very expensive, because I'll be fancy, I'll develop a transparent product, a product that you just click and it goes to the so we need a sort of innovation, and also we need a more total approach, because for me to introduce it, there has to be some people coming in to play a part in terms of subsidization. Once the product settles in the market, then it lives its own life. So that's key to me, and I refer to the supply chain from the manufacturer's perspective.
Thank you. Michael?
Yeah, I think for me it's just to emphasize what has already been said, and good coordination amongst all the players. I think is something that is really key, a common understanding, something that can also reduce stockouts, because this is something that we experience among a lot of the community pharmacies, which is basically an interruption in business. If today I can get DMPA SC and then the following month I cannot get it, then they start thinking about why would I engage this. So if we can address all that, the supply chain management, affordability and accessibility, then we are on the right path towards TMA success.
Thank you, Daniel. As you can see, everybody's plugged in and we are ready for the journey to self-reliance. So what do you say in closing?
Yeah, so what I will say is that as we are still committed in providing that enabling environment to ensure there's access, to ensure there's affordability and also sustainability of family planning service provision. And this is not done just as only within just a mention of the strategy, but in action in terms of we spearheading the expanding of our method mix with new methods, even as we try to talk about the case for hormonal IUD, self-care, we are trying to ensure that is actualized. Also, we are trying to see how can we reach to all these stakeholders to ensure that they can be able to support us for all the Kenyans, wherever they are, they can be able to access quality services in each of the market segments. So for us, we'll always be committed and ready to receive any support and be able to provide the right guidance. Thank you.
Thank you. That brings us to the end of our discussion. Can we please just give them a round of applause as before? Yeah, I'm aware the TMA discussion is usually quite difficult because this is a new area even for the country. We've only had 2 years for the strategy. So there are a lot of issues that are still unknown, but I'm really happy that the conversation that has come out is putting us on, we seem to be prepared, I think, for the 2026. I think we just need to continue putting in the momentum to ensure that when that time comes, we're able to ensure that KEMSA gets 100% of its budget from the domestic resources. So we'll invite a couple of questions. I think we still have some time. So please feel free. I can see a friend of mine from Maisha Meds there as a question, and then we have Lawrence here. So let's start with the three. And then please just introduce yourself and do mention who you're directing that question to. Thank you. So we start with Lawrence, and then we'll go to Dan, and then then somebody.
Good morning, everyone. Lawrence, executive program manager, and my question is linked to Kenneth talked about, especially closing remarks around the user and the feedback loop. And I was just reflecting and trying to link it to the recently released memory care network and the community units CHPs. And I'm just wondering whether we can actually, or you have the task force has thought about using them as a service delivery model, whether the MOH or the Pharmacy and Poisons Board have considered training some of the CHPs to advance the total market approach at the community level, and so create some of those impact groups that Kenneth was talking about. So I guess it's directed to MOH, the Poisons and Pharmacy Board, and to some extent also.
Thank you. So, yeah, that is directed at MOH at the pharmacy, but we'll hear from, let's get from Dan.
Hello, everyone. Thank you so much for this really informative talk. My name is Dan Rosen. I work for Maisha Meds. We provide software to about 1,000 pharmacies and clinics in Kenya, and we have data for those connected in the SI. My first comment is that we're very keen to try and integrate that data into government systems to inform decision making in the private sector. I was really pleased to hear some people that I use of emergency contraception currently in the private sector. In our network, I think it's 55% of all sales of hormonal contraception and 60% of every shilling spent is on emergency contraception in the private sector. So I guess the challenge I have for the panel is when we're thinking about shaping the private sector, how do we balance the want to get more CYPs out of each shilling against the choice of the patient who walks in, and how do we create these environments where like you said, it's not about being a vendor, it's about being a service provider. It's about choice. Thank you very much.
Thanks, Dan. Let's get the third one there. I think I'm told time is up.
Yeah. Greetings to you all. My name is Emmanuel Busera Mohammed. My first question is to the manufacturers. You mentioned something about delays that occur because of WHO pre-qualifications. And I'm well aware that WHO is not the only health organization in the world. From the history of the corona pandemic, their own representative in Italy, Dr. Francesco Zambon, came up with certain revelations that put them in a very awkward policy formulation that is going to make this kind of regulations not deter your production so that people can get what they need in the time that they need it. And my second question goes to KEMSA. You spoke of reliance on data, talked of NFPA and the reliance of data from the private people. In terms of control and the accuracy, what role are you playing to ensure that whatever information you get is reliable, is accurate, so that the public can actually consume that which you have really looked at? And my final question goes to Daniel from the ministry, I think, Ministry of Health, right? Recently, the government has rolled out a program of healthcare within the local communities. In terms of building capacity, instead of relying on the private people to execute that which the government needs to do, what are you doing in terms of setting up study groups and training units so that the local people can also be empowered within this whole sphere of the healthcare system, especially the women in the healthcare systems? Thank you.
Thank you. Those are three excellent questions. Can we start with Daniel, and then we come to Michael, and then we'll get KEMSA, and then Willis will close it for us.
Okay, thank you. So I think I'll be able to, I think the last question is related to what he asked, Lawrence asked about the user. So, and it ties to first the WHO pre-qualification standards and what we have in country as RAPTIs for the introduction of new method is trying to speak to a quality. So that's one aspect in terms of how are we speaking to quality, because we want that the products that are coming into our system or our healthcare system are of good quality. So they're meeting all those standards because they're trying to see that they are doing no harm to our clients. So in going down to what we launched at the Smart Care networks during the Jamhuri Day, is that within these networks, there are some things related to FP that we are doing at the community unit. So the first thing is what he mentioned about the community pharmacists. So that within that, they're being trained to offer family planning at that level. You're also having the community health promoters that are being trained to offer the short-acting methods. And with what they have as is the electronic community health information system, we're able to have a line list of all the clients that have visited and the short-acting methods that they have been able to provide. So we have trained them to offer the short-acting methods. But not only that, what we have linked with is with a linked facility. So the smart primary network works in the sense that that person, as they meet the client at the household, they're able to refer. So we have established our referral networks. So the linked facilities be able to see what the SHV is referring to that facility. So the smart primary care networks are linked to the primary facility that the SHV is getting resupplies for those commodities. So they're able to refer for the lacks, so that they're able to get, because with the quality again, we have not trained them to offer the IUDs and some of the implants. So we are encouraging them to refer to the linked facility for them to get the quality services. So that is as far as quality is concerned and what we have done at the community level. For the youth and the women, of course, they are not healthcare providers. So the best we have been able to do is creating awareness around this. So we have been able to come up with, once they fill the facilities, we have been able to ensure that we have those IC materials with support. We have been able to come up with IC materials. And the last miles distribution is at that service delivery point. So we are ensuring that the service delivery points have the IC materials. We are ensuring that the CHPs are working with the IC materials and job aids for family planning, which they are able to share with the users. So those are as far as what we have raised and how we are responding to that. So I think that's maybe with the last bit, she can elaborate more because I sit within with KEMSA, we have done what we call the integrated LMS. So the integrated LMS is one of a kind for the programs, for the FP program. And for those who are managing the quality of data, is not solely KEMSA, but we have formed what we call the national order management teams. So national order management teams were able to approve all the requests from the facility level and sub-county level, and we have put their validation rules. So for any quality issues that are flagged out, and the county have to rationalize that before we do any reissue with them with any commodities. So it's more of multi-sectorial members working on the quality for that. Thank you.
Yes, let's hear from Michael, but let's make it short. The timekeeper is on our case list.
Yeah, I think for me it's just to maybe respond by saying the evolution of community pharmacies is something that needs to go out there to all the pharmacies as part of strengthening, so that pharmacies don't look like kiosks or don't operate like kiosks. So you mentioned something about people coming and asking for emergency contraceptive pills and a sense of embarrassment and so on. PSK is very, very keen in ensuring that we become service providers. And part of that is ensuring that your facilities actually enable to do that. We know that typically people open up drug shops everywhere, and it is whoever is able to give the prescription or piece of paper and get the medicines and offer back the money. When it comes to FP service provision, we are speaking to the pharmacists and saying that, you know what, if you want to get into business, think long term. Have a business model that is able to accommodate all these services that you can also embed, so that it's not just family planning services. We're having immunization coming in, we're having other forms of counseling and other forms of services that can be provided, so that there's a value proposition towards over and above just providing FP services. So again, feedback by end users. This one, again, depends on how that pharmacist is actually trained and upskilled, yeah? Because over and above providing pharmacovigilance platforms, which has already been publicized, one by the regulator, that the public, in the event they experience anything that they feel they need to notify, there is already public information out there. You go to the website and you can communicate. So that is one of the feedback mechanisms that we have for the end users. However, pharmacies are also encouraged, again, to provide their own innovations, whether it is the use of technology, SMS services, websites, Twitters, and so on, where they can report back on the use of FP products.
Yes, thank you, Michael. Let's hear from.
1 minute.
Yeah.
Three things, because you mentioned the manufacturers. One is that we work with academia. It's just that in Africa, we don't have those patents. It's not a very specialized area, but in developing countries, they come and sell to us innovations, and we partner with them. Population Council, we own the product. Hormonal IUS with Population Council. So there is a percentage of hormonal IUDs that are given free of charge as part of the guarantee. You are just not utilizing it. But I know Mary Stopes has used it before, Chapiego, and even private doctors in Kenyatta Hospital. We have innovation scholarships for science that we give out. You apply to the Bayer Foundation. They are there. Africans are just not using them. So there is a lot we do with academia, just to answer you direct. And then two, the cost of setup is what I was talking about. I think WHO has already alluded to. Now, without mentioning a company in my previous employment, The whole delegation came to Kenya, and after 1 week, they already said it's not possible. We know the index, ease of investment in Africa. We can check it up. We went to Ethiopia. They gave us a 5-year tax holiday. They gave us 500 acres of land free for 5 years. Set up, return on investment, then we start charging you. Already it gives you there is an induciveness that is being, and then finally, the cost of doing business in FP prohibits people from even setting factories in Kenya here. You can imagine in our company, the inventory, the amount of money that is outside there as credit is like 2.5 billion US dollars. I mean, 2.5 billion Kenya shillings. It's paid after 6 months, 3 months. If you're not liquid, you cannot do this business. I can tell you for free. It needs a lot of inventory in terms of money.
Thank you, Willis. Let's hear from Kemsa, and then we'll have just one last question here. Just microphone here, then you, and then we move here.
Okay, in terms of remaining in control, when we are supplying to the private sector, we are treating the private sector as an extension of the public sector. So the data they report it through the public sector. And as Daniel has mentioned, we are leveraging on technology. The LMIS flags out any data issues. So whenever there are data issue, the NOMT, the National Data Management Teams, now goes to the ground and checks what is happening and rectifies anywhere there is any form of mistakes. Thank you.
Thank you, Miriam. Let's get the last one and then we close the session.
Yeah, thank you so much for the very insightful discussions. I think mine is not a question, but a thought. And looking at the current UHC rollout, the way we have structured, for example, even the funding in terms of insurance, we realize at primary healthcare level, which is like level 1 and 2, basically, all services are supposed to be free. The CHPs that are going onto the ground, even if they are carrying family planning commodities, they are also free. So the question is, where is the space for total market approach? And so some of my thoughts are, we may want, like you said, and I agree with you, Dr. Okumu, that it's we are learning from the strategy, that we may want to go into market segmentation. We may want to ask ourselves, who does total market approach target? So that it can get some root. Otherwise, where we are at now, if you're having free, CHP is bringing my commodities at my doorstep for free, the space for total market approach starts to diminish. So we may want to think about who is our target, where is the market, and definitely we have a big middle class that wants to pay, wants to get something different. So maybe those are just some thoughts in terms of looking at implementation going forward. Otherwise, if we just look at it from all the way to community, it might just be a bit of a challenge to actually be able to implement and get results out of it. Thank you.
Thank you. Those are really issues in terms of, and that's the reason why we are saying that we need to constantly keep doing the market segmentation. We need to do market analysis to know who are we delivering which commodities to. Because there will always be in a community, there will always be people who are willing to pay for the convenience. But how big is that market? So that we're able to encourage the private sector to engage with them. But those are issues that I think as we continue engaging in this area that we'll need to try and find solutions and learn in the process. So I just want to close it there and thank you very much to the panel for the very insightful discussion, and we look forward. For the questions, thank you very much for the questions that you've presented, and I'll hand over to the MC.
All right. Over here. Thank you so much. You can appreciate the panel even as they come to their feet. And even before you sit down, ladies and gentlemen, I want us to appreciate them much better. I know there's some feedback, Dogo. I want to appreciate them much better with the Thunderstorm Club. They've started the day off in a very awesome way. All right? So again, prepare your hands, 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 prepare your hands. They've done a good job, the team led by Dr. Okumu. Let us start clapping, pole, start clapping slowly. Increase the tempo, increase the tempo. Let's go. One more time, let's do it. Thank you. May I have your seats, ladies and gentlemen? Thank you so much for that. A photo. All right. Photo time. Sorry. Just one photo, one group photo. There's a photographer somewhere. You can just take us a photo. Eh? Yeah, so that's the camera there at the back. Those two cameras. All right, thank you so much. One more time, let's appreciate them. Thank you so much. Let me now hand over to Kamande, Dr. Pahe.
Great, thank you so much. Good morning, everyone. We've had such a great session. I promised you yesterday that you didn't want to miss the TMA session, and they've been able to deliver a lot of thoughts. I at one point when Willis was talking about the cost of doing business in Kenya, I was thinking, so should I then now leave this biashara of health and move to, I mean, there's money. All right, I'm being told, again, I represent people who are vertically. All right, there I go. So can everyone see me now? Yes, perfect. Great. So, okay, thank you, Alex. So I've been thinking, so do I go to Ethiopia? I mean, there's places you can get 5 acres of land and tax-free for 5 years. Do we go do FP business there, then bring it this way? Anyway, very interesting ideas. Thank you so much to that panel. So I'd like to recognize a team that's joined us today. We had people who were not able to join us yesterday, but they've been able to join us today. I'll start with the team from SIF. I know Julie is trying to not give us anything with the mask. So maybe stand up and say hi to us.
Hi, everyone. Apologies, I'm recovering from a terrible cold. My name is Julia Greenland. I'm a director in the Girl Capital team at the Children's Investment Fund Foundation.
Thanks, Julie. We're glad to have you and we wish you a quick recovery. Is there anyone else who didn't join us yesterday? Kindly just stand up and wave, just so we can know you missed out on all the dancing yesterday evening. Anyone? Great, good. So we'll move to the next session, and we'll be discussing family planning commodity security at the counties. So we have a lot of good discussions that we have at the national level, but to what degree does all this trickle and make sure that the woman in the village, in your village, if you come from Kenya, think about your village at home. The woman who is next to your home in Shats, at your village, how easy is it for them to access commodities? How many times do they go to the facility and they're told, come back after 3 weeks? What does what mean? All these discussions, to what level trickle down? I come from a county that's been cut off by the rains at the moment. Someone was telling me I cannot see my mother because of El Nino. I can't access Kilifi County right now. There's a facility next to my mom's homestead. It's called Matangoni. And we are part of the Desip project and all. Are they going to get FP? As I'm talking as the Desip project director, does the woman who accesses Matangoni Health Center, are they going to be able to get FP when they get there tomorrow, after Dr. Pahe has finished the Desip Family Planning Conference? So let's see about that. To what extent do all these discussions, to what extent are they actually actualized at the counties? And to that, I'd like to welcome Teresia, our RH coordinator from Narok County, and she'll be handling the first presentation, and she'll be co-chairing the session with Monica. Monica is a senior manager for the Accelerated Project at PS Kenya, and will be contributing and leading to this discussion around commodities. Because after all is said and done, when the woman walks to a facility in the village, they should be able to live with the FP commodity that they need. Thank you and welcome, Teresia.
Thank you, Dr. Pahe. I think I need help to some people to help me to move the chairs so that everyone can see. Yes, all protocols observed. Ladies and gentlemen, good morning. Good morning. Can everyone hear me? Yes, it is my pleasure to present to you this morning a presentation on family planning, commodity security at the county level. My name is Teresia Mutogia. I work for Population Services Kenya, and I will be assisting moderation with Monica Dhumbe. Yes, next slide, please. Yes, the purpose of this panel discussion is to share experiences from national, Desip-supported counties and KEMSA in working towards family planning, commodity security. And the objectives will be to highlight the family planning commodity status at the county levels, to discuss the key interventions used by the counties to strengthen FP commodity security, and to bring to light the persistent gaps and strategies to address them as we work towards Family Planning 2030 goals. Next. Yes, most counties have made significant progress towards commodity security, and I must acknowledge that we have put in a lot of hard work, and it has been a lot of milestones that we have put to be where we are today, but yet we are not there. And that tells us that we need to put in more work, we need to do a lot of strengthening to ensure that our counties have the commodities, and then we can say that we have won the battle. When the Desip project was being designed, commodity security was one of the challenges that the project intended to address, and this was also affirmed in all the 19 counties that were implementing for year 1 and year 2. During the county entry meetings, when we went to those counties, the county leadership, the executive leadership, the county CHMTs affirmed that commodity security is one of the challenges that needed to be addressed. A landscape analysis that was done at inception noted variable commodity securities in the 19 counties, and only 37% of the counties had the capacity to conduct forecasting and quantification. There was also an inception meeting with the Division of Reproductive and Maternal Health that also identified the need to finalize the reproductive health commodity security strategy that would ensure that counties have access and availability of quality family planning products. Then when the project was also starting, Desip project conducted service availability readiness assessments that also brought out the issue of commodities stockouts, that in some of the facilities, they were even lasting for more than 7 days. So for the 5 years that the Desip project have been implementing, the following are the interventions that have been put in place to ensure that commodity security have been strengthened. And on forecasting and quantification, a lot of capacity building has been done at the county level. We have trained TOTs to ensure that there is sustainability and continuation of mentorship, even when the Desip project will be gone. The mentorship will still continue because the TOTs will be left with the counties. Support supervision has also been supported by the program, and mainly this support supervision entails mentorship for FP commodity management at the facility level to the healthcare workers. The project also participated in donor-led commodity security group meetings and FP logistics technical working group meetings, and provided technical support. This training, which is known as FASP, that is forecasting and supplying family planning training, and also post follow-up, was done in selected counties, especially for year 3 and 4. For Narok County, Homa Bay, Kilifi, and Isiolo counties, we have done follow-up to ensure that what the healthcare workers have been taught, all of the sub-county pharmacists are able to implement. Also, we supported counties to develop county-specific forecasting and supply planning. On commodity stock status and redistribution, we conducted a commodity stock verification exercise and later redistribution. This was done in all the 19 counties, and they were spearheaded by the county pharmacists across all the counties. We supported support supervision, data quality audits, commodity supply chain audits across the counties, mentorship to the healthcare workers on the correct use of MOH 512, that is the FP register, and FCDRR. The program also strengthened the use of RH dashboard and facilitated commodity dashboard reviews across the counties. We also supported stakeholders, commodity management meetings, for example, in Homa Bay and Narok counties. And in year 4, UNFPA, through FCDO funding, was able to procure FP commodities aimed at minimizing stockouts in the Desip-supported counties. And also recently in Narok County, the program supported a data cleaning exercise, which was spearheaded by the county pharmacist. And I'm glad that he's here. He will be able to talk more on that during the panel discussion. And also, I think last month, we supported at LMIS training in Samburu, Isiolo, and Marsabit counties. Yes, this diagram just shows the flow of commodities from the facilities, which we call the last miles, up to how they order facilities from their facilities up to KEMSA, and how they are delivered, and also the DESIP role that we play in ensuring that that process is successful. So at the bottom, we have the facility, whereby the facility healthcare workers will do their reports. They submit to the sub-county pharmacist, that is the FCDRR form. They will fill and also request their commodities. And at this stage, the DESI project will support stock verification, documentation, and reporting, just to ensure that the data is concordant from the FCDRR and also with the 711 reporting tool. Then they will submit their reports to the sub-county pharmacist, who will review the orders and submit them for further approval. And at this stage, the program will follow up facility commodity status, reporting and ordering. Then at the county pharmacist will review the orders and submit them to KEMSA for further ordering. And the DESIP role will be to follow up with the county pharmacists on submission of orders, support technical working groups to track commodity status using the RH dashboard. And finally, at KEMSA, they will process the orders from the facilities and delivers them, except for a few counties, and KEMSA will deliver them up to the last mile. That means they will take the commodities to the facilities themselves. And at this stage, the program will do frequent follow-ups on the orders from the 19 counties, but currently we are working with 12 counties. And then they will also follow up on FP commodity at central level stores. On commodity security WGs, when the project was starting in 2020, only one county, that is Mandera County, which did not have a technical working group. The other counties had technical working groups, though they were not active, but they existed. So the project supported a formation of a technical working group in Mandera. And in other counties, we strengthened them to ensure that they are active and they are meeting on quarterly basis. Then for 2023, this year, the project has supported all the 12 counties to develop their annual work plans for financial year 2023-2024. And this was key for us because we were able to lobby for allocation of resources for commodities in facilities. And most of the counties, especially the county that I am in, which is Narok County, I have allocated a budget for that. Next. On total market approach and reproductive health commodity security strategies, I know this one has been covered extensively by the team that was here. But for the program, this is what the program has been able to support. In collaboration with the UNFPA, the DESIP initiated the planning meetings with the Ministry of Health to conceptualize the TMA strategy. That was in 2019. Then the project supported the development of the term of references for the assignment and recruitment, and they recruited an experienced lead consultant to head the process. Also, options, in collaboration with UNFPA, they supported the ministry to develop a RHCS strategy to ensure that there is better availability and accessibility for the FP commodities. The program also took a validation exercise for these two key documents, and Currently, we are continuing to support TMA disseminations across the counties and sub-counties, and also tracking its implementation. On social marketing, I would wish to talk a little bit about our social marketing and our commercial department. Sylvia has just said that social marketing contributes to 60% of the commodities in the market. And in PS Kenya, we have a commercial department. We have a commercial department whose vision is to leverage on private sector channels to increase the access to quality products and services. And these products are aligned with PS Kenya priority health areas like HIV. And for HIV, we distribute trust condoms, HIV self-test kits. For child survival, we distribute WaterGuard, PNG water purifiers, aquatabs. For malaria, we have the SuperNets. And for family planning, we have FemiPlan, FemiJect, FemiPills, those are the pills. And we have the long-term methods, which are IUCD and implants. And these products are distributed through a channel. From PS Kenya, we have distributors who help to distribute the commodities to the wholesalers, and then the wholesalers now will distribute the commodities to the clinics and pharmacies where our clients will be able to access them. The Desip role in this has been to support awareness campaigns, distribution and promotion activities, and capacity building of healthcare workers by use of manuals and sensitization sessions to the healthcare workers. And below we have the photos of the commodities that we distribute. Next. Yes, since the inception of the program, that is in 2019, this is what we have been able to distribute, or rather our sales. And we had a target for condoms to above 21 million, and we were able to achieve, I think there's a part that is missing. Yeah, but we were able to achieve 18 million. For pills, we distributed 3.2 million. We had a target to distribute 3.2 million, and the target was 2.7, sorry, and we distributed 3.2 million. For injections, the target was 67,000. We distributed 53. The reason why we were not able to meet the target for injections was due to the competition in the market. There are other cheaper brands that are out there, though we were at around 84%. Next. Yes, this graph just shows a comparison between, it shows a comparison of stocks at the facilities. And yeah, this one now goes to the men in the house. Which color is this? This one, here. Yes, purple. Really, this is purple. Yeah, all the men in the house, please repeat after me. Turquoise blue. Yeah, this is that. And then all the ladies in the house, you can repeat after me. Midnight blue. Yes, and then all the young people and those who feel young at heart can repeat after me. Copper brown. Yes, those are the classes. And if you want to know more colors, you can see me after this. Yes. Now, these are the national stock status, including the stocks at the facilities and at KEMSA. And the turquoise blue now, this one, are the stocks that are in the pipeline that KEMSA have ordered. They are yet to get their warehouses. Then the copper brown, are the stocks at KEMSA. And then the midnight blue are the stocks at the facilities. And then we have a minimum. At all times, KEMSA are supposed to have minimum stocks of 6. Here, they are the months of stocks. So like for IUCDs, we have 261 months of stocks at the facilities. So that shows in other commodities like implants and DMPA, we are understocked. Yeah. Next. Yes, I beg to stop there and invite Monica to continue with the sessions. Now that we have had the commodity stockers status at the national level, we want to hear what the county, pharmacists, and other panelists will say about the commodity status at the county levels. Thank you very much.
Thank you so much, Teresia. Please, can we have somebody getting at the seats here? Before we went to the real commodities, I wanted to ask what are commodities, but now I think she really burst my bubble. I really wanted to go to somebody and ask what are commodities. But we are very grateful that we are able at least to unpack that and show you at least those are the real things that are used. They are the real, the pill, the IUCD, and all that. So in this session, we are going to have the counties come here and tell us the real status, what has happened in their counties through the Desip program, and what is the status of the commodities in their counties. So kindly, you can come to the stage so that we can do the introduction here. I know we are short of time. You cannot tell me 30 minutes left when I've not begun. Sorry, on a light note. Kindly, let's make our way to the stage. We know ourselves so that we can have this discussion. Maybe faster. People can stretch, I don't know, or something. Very fine, how are you? Welcome. Welcome, Emily. So very fast, we'll just have a round of introduction, starting with Emily.
Good morning. My name is Emily, the County Records Officer from Elgeyo Marakwet County.
Good morning, everyone. My name is Dr. Gilbert Korir. I'm the County Pharmacist of Pokot County.
Good morning, all. Bonaya Godana, County Pharmacist, Marsabit.
Good morning, all. I'm Dr. Dan Gere, County Pharmacist, Narok.
Good morning, Wycliffe Dunde, County Pharmacist, Homa Bay County.
Good morning, Miriam Kimani from KEMSA.
So thank you so much, ladies and gentlemen, for that introduction. Very quickly, Dr. Gere from Narok, you can give us the status of the family planning stocks in your county, maybe in a scale of 1 to 10. 1 the lowest, 10 the highest, and you can tell us why you are rating at whatever you are rating it at.
Thank you, Monica. The status of our FP commodities in Narok, I will give it at 8 over 10. This is because currently in Narok we have all the family planning methods available, and also most of those methods we are stocked according to plan. We have the stocks between 3 to 6 months of stock as per the requirements, except for a few like implants. One rod we have less than 3 months. This was due to the national stock out. Then we also have level plant and IUCD, which are over 6 months of stock. Thank you.
Thank you so much, Narok. What about West Pokot, Dr. Koril?
So thank you. As for West Pokot, I will rate it at 8 for with the help of HealthRight and other partners in Desip. We are able to ensure that all the facilities are reporting. Unlike when they first came in, when the reporting rates was at 56%. So with the reportings, we ensure that all the commodities are in all the facilities, and with all the facilities having the commodities, it's much easier for them to access them. Now, for all the methods, they're available, including the latest ones which were supplied this month. That is DMPA subcutaneous and hormonal IUCDs. This was made possible through the support of Desip, which helps us train our staff for them to be available. And the reason why we can't give it a 10 is because some of the commodities are stocked beyond 6 months. That is male condoms and IUCDs. Thank you.
Thank you so much, West Pokot. What is the status of the Lakeside, Homa Bay County?
Okay, thank you. At the moment, we are being supplied by KEMSA. So I can say we are at 10.
10%?
Yes.
10 over 10?
10 over 10 at the
Wow.
moment.
So give us why. What are the reasons you think you're at 10 over 10 at Homa Bay?
Okay. In Homa Bay, we make our decisions based on the data. And we tend to take partnership very seriously. So our partnership with Desip is that we can describe it as that which is synergistic and very effective. So when we make our quantification and quarterly orders, we analyze the fiscal count, the patient flow, and then we place our orders. So we are okay.
Thank you so much, Homa Bay. What about Emily? Tell us about your county.
Thank you so much. For Elgeyo Marakwet County, we will rate at 8, mainly because we had stockouts last month, but KEMSA are now supplying, and there's a distribution to the health facilities. Also, we rely on donor funding, fully 100% on donor funding, and the county has no budget line for family planning commodities. So despite the delivery to the health facilities, we also need to have a system whereby we can monitor the commodities from the dispensing, and also real-time data from the health facilities, so that we can have the actual commodity status in a specific time when needed. And also when you look at the issues of stockout, there is also an overstocking of some of the commodities, like for example, the IUCDs in our county. We have over 6 months stock and implants. So we have some commodities overstocked and others are out of stock. But currently we are okay now.
Thank you so much, Emily, for giving us the status of Elgeyo Marakwet. What about Marsabit? At a scale of 1 to 10, how would you rate the stocks or family planning at Marsabit?
In Marsabit, I think I'll rate us ourselves at 5 over 10. We are suboptimal in most commodities, except male condoms. This is largely attributable to issues of data quality. Our county, in terms of human resource, we only have a skeleton staff. Facilities are manned mostly by either 1 or 2 persons, and I don't know whether we are overwhelmed by the workload. Our data is so, though the our reporting rate, we still have a lot of issues of data quality, and the suboptimal levels of most of those commodities is attributable to that poor data. So I will rate ourselves as maybe 50%, at 50%. Thank you.
Thank you so much, Marsabit. I think that is very honest of you, and I'm sure you will go to be working with all the programs that you have to bring yourself to around 80%, where maybe the rest of the counties are. Going forward, I know we put a lot of interventions, at least to make sure that we have commodity security in our counties. So Narok County, Dr. Gere, could you share with us the best interventions that you think you have put in place in Narok, particularly to make sure that you are commodity secure?
Thank you. In Narok County, through the collaboration with Desip, we have been having quarterly commodity security technical working group meetings. This is where we invite the sub-county commodity and data managers. They come and discuss the commodity stock status for each sub-county and also for each facility. Where they see there is it's not stocked according to the plan, we initiate measures to either redistribute the commodities from the facilities with excess to the ones with the less commodities. Again, they also check on the reporting status of the facilities, because we know For us to have commodity security, facilities must report so we can view their commodity stock status. So we also go through the facility reporting system, look at the facilities which are not reporting and follow up with them. And currently, I think we are doing over 90 new facilities which are not reporting are new facilities which were launched, and also some private facilities. But we do follow up to ensure that each facility reports. The other intervention we have done in Narok is last month we had a data cleaning and allocation meeting with the sub-county pharmacist, which was also supported by Desip. This we brought in the sub-county pharmacists to look at their data in the Kenya Health Information System, that is KHIS. So they open the system and look at each facility data for each product. So where they see there's an outlier, they call that facility to verify if that is correct. If it is not correct, they correct it, and then they do the allocation later on. And for allocation, we use the KEMSA, the Logistic Management Information System from KEMSA, which gives us an opportunity to allocate according to the monthly consumption of each product. So we cannot order excess or we cannot order less because it gives us what has been used, what has been consumed in a month, and we can rationalize that number according to that monthly consumption. So we use the KEMSA Logistic Management Information System to do allocation. So we do data cleaning first through the KHIS, then we do allocation for the commodities. The other intervention we have done is through PS Kenya and Desip, we developed forecasting and quantification report, which is going for 3 years, 2022 to 2025. And this report has helped us in estimating the requirements for family planning commodities in terms of costing and also quantities. And from that report, we had seen that for Narok County, in 2025, we will require like 66 million for FP commodities in a year. So the reports have also helped us in bringing in commodity security, because we do also analyze using that report when we are comparing our orders. The other one we have done is we have also been printing and distributing and disseminating the current version of the facility consumption data and request forms. This one we also we have received a lot of support from Desip. We have disseminated the current version to our facilities, which means they are using the current version in the Kenya Health Information System so that we get the right data in the system. Apart from the few newly launched facilities and also some private facilities, all our facilities have the current version of the data tools. Thank you.
Thank you so much, Narok, for highlighting that. You mentioned widely the Logistical Management Information System. Dr. Koril from West Pokot, could you easily tell us, apart from all these technologies being available for management of stocks, how come the counties look to be struggling with these interventions and especially the innovations?
Thank you. The way LMIS works is that it displays the consumption data after pulling data from KHIS and aggregating it for MOH 711 and report for FCDRR, which is for commodities. So if there's some challenges in concordance between MOH 711 and FCDRR, making use of LMIS will be a challenge, and that I think majority of the counties are struggling to address that. Number two, if there are stockouts in facility level, generating the consumption data will be an issue as well, and stockouts at KEMSA. Thank you.
Thank you so much, Daktari. From Homa Bay, you told us you had 10 over 10. Could you tell us maybe the other factors which have really contributed to your success of achieving at least 10 over 10, if not 11?
Okay. Yeah, in Homa Bay, as I said, we work as a team. We create that synergy whereby we maximize on whatever we have to make big impact. So for us to be at 10, we make sure our reports are clean every month, and we work closely with KEMSA. KEMSA usually call us all the time if we have an issue arises in our stocks. So in that manner, we are able to be on top of things. As we speak right now, we are planning to have technical working group on 7th of December with the support of Desip and Afi Ugavi. We have just been discussing outside there this morning. So it means we are always in the move, on the move. We work together. We do support supervision regularly, especially those hard to reach areas. And the farthest island is Remba Island. Yes, we have been going there several times to make sure those people there access family planning. We have also hard to reach areas. In Homa Bay, we have a place called Apuko. In Karachonyo, a facility called Agera is there. We go there to make sure those people also access commodities. You remember, Desip, one of the point in Desip, meaning of Desip is sustainable and equitable. We ensure equity. So to ensure equity, you must have the commodities to the poorest and the people who live in the hardest areas. People like who stay in Kiwa, we make sure we reach there. And we do mentorship. You see, we still have, Homa Bay is a rural community setup. We still have stigma. We still have beliefs. So through talking to healthcare workers, training them how to communicate to the community on the meaning of family planning, it helps a lot, because some people initially used to think that family planning is having one kid or not having a kid or whatever, but we tell them family planning is about planning for your family. If you have the ability to care for 4 children, then make sure you plan for those 4 kids. If you cannot, plan for 2, plan for 3. And these commodities are not there to make sure you don't get a child. They are to make sure that this family of yours is well spaced and well supported. Thank you.
Thank you so much from Homa Bay. From KEMSA, Lillian, could you tell us the progress you have made to hear LMIS? At least we know it is domiciled at KEMSA. The progress you're making, and maybe you can tell us some of the handles you're facing while at it.
Okay, thank you so much. In terms of success, we've had tremendous success. As we speak, the counties receive their stocks every 3 months, which is contrary to what was happening, because previously they will have to wait for the EMMS orders and tag along the FP product. So this proved as a challenge. You find there are counties that don't really purchase in every financial year. Like the last financial year, we had counties like Sumu had not really ordered for any MMS products. So you'll find the gap of a year, the family planning program misses out on such. And then we also leveraging so much on technology. We have the integrated LMIS that is a proactive decision support system for just basically to support in commodity security. In this, we have the SEWAS, which is the Commodity Early Warning Alert System that shows visibility of the commodities at KEMSA. I think it's the same that TRISA has used. So when you're in the counties, you're able to see what is in KEMSA, and we're also able to see what is in the facilities. Also, we are able to see the procurement in progress. So the counties will be able, like they have talked about implant. When they go to the system, they can see what is being procured and when it's arriving. Another thing that is featured in there is the commitment from the development partners and the government. And then another component of the system is the LMIS itself for ordering. So we are using data to resupply. So there's an algorithm that is in place after factoring the consumption data of the core counties, we are able to resupply. So we are able to avert so many things like stock out, overstocking, and even expiries. Another thing that we have is We have a functioning national order management team that is able to sit every month, discuss and review and allocate commodities. So when they go back to the sewers, they can see Homa Bay County is overstocked with a commodity. They will not allocate them. What they will do, they'll activate a redistribution strategy just within the county. And then finally, in terms of the progress, we have the EPOD. The EPOD has been able to ensure that the commodities reach the last mile. So we had confusions with other facilities that have the same name but different counties. So to solve such confusion, the EPOD has really been able to help. Again, on the hurdles, we have a few hurdles in terms of data. As you've heard, if the data is wrong, the commodities that will be resupplied will not be sufficient. So again, we go back to stockouts, expiry, and all those kind of challenges. And then another thing is our domestic funding. We've not been able to have a consistent domestic funding, and we largely rely on our development partners. Thank you.
Thank you so much, Lillian. Lillian has mentioned the issues of data in family planning data, which really brings a lot of inconsistencies. Same to Dr. Gere from Narok. He also mentioned that they get outliers and they have to clean the data here and there. So Emily, could you tell us some of the factors that contribute to unreliable data, maybe at the counties?
Thank you so much. Some of the factors that affect data include issues of capacity building of staff. And remember recently we've had revised tools, and if there's no capacity building of those staff, each and every staff will be giving us different information as per their understanding. So the challenge of indicator understanding comes in, and therefore discrepancies in data reporting, and also it will not be uniform. The other issue is in terms of documentation. We find that there are documentation gaps from the facilities all through to KHIS. We find incomplete registers in some areas. We also find, especially on commodity status, they are blank, and also the issues of the MOH 711 and 747, that is the FCDRR reporting, we have discrepancies. The other issue when it comes to unreliable data is ownership at the facility level. We find most of the facilities do like clearing and forwarding. They want to meet the timelines of reporting, and maybe because of the issues of high workload, they are just doing the reports for the sake of meeting the timelines. So they don't have time to review their reports because of the high workload, or maybe the issues of high turnover in some of the facilities. The other issue is in the issues of reporting, non-reporting. So you find some of the facilities may miss to report their FCDRR. So it will affect the data being keyed to KHIS. Thank you so much.
Thank you so much. So from Masabit, what do you think are the ways that we can improve these qualities of data, especially what Emily has talked about? And now that we want to bring you to speed, maybe the rest of the country.
The way to go is to have regular data verification meetings, maybe quarterly or even monthly. But we've always thought of along those lines, but Marsabit is very vast, very large. A lot of resources are required even to gather people at a central place. The county government and the partners that are around normally shy away when it comes to, gathering people at a central place because of the financial consequences that are involved. But we intend to do maybe sub-county based quota verification, the quarterly data verification meetings specific to commodities. We also intend to sensitize our health workers at every opportunity time when it arises concerning the importance of having quality data for decision making. We, of late, actually, Desip has come in. The LMIS platform is now in use. We've trained a few healthcare workers involved in commodity management, and we intend to cascade the same to all the, at least to the in charges of the health facility, all the health facility in charges. And I think with that, situation will improve.
Yeah, thank you so much from Masabit. I know we are really short of time, so I'll allow maybe for 5 minutes questions, then I can give them just to say the last thing that they really want to say to this panel before we close. So any questions for us on security of the commodities? Somebody give the mics, please.
Thank you so much for the very good discussion. We know that the people are thinking about
Yeah. Thank you so much for that question, Natako.
Good morning.
Morning.
Thank you. Thank you for the good discussion. My question was about the reported data. Because this will mean that the data will be from a particular of the accurate. And this is an example of the community parents. They are giving community planning commodities to the community, and actually they are not reporting anywhere. Some of the countries are trying to engage in, and the effort seems like has not come with good foods. They are resisting a lot, and maybe I can suggest that they be given maybe something like an email so that they can be reporting so that the data goes to the engaged areas. Thank you.
Thank you so much. That's a very valid point. Anybody else? Yes, from Samburu. Dr. Ezra Leknit. Yes.
Yes, good morning.
Morning.
My question goes to so what I would like to what are the mechanisms that are put in place to ensure that there are no national stockouts of commodities. For example, in the past, we have had the things like LST, LFT, taking out of stock. We have products taking out of stock, leading us to super. So, what are you doing in terms of forecasting for that to make sure that we don't have stockouts nationally? Number two, law here children. So, as a country, we are getting affected by this because we do the orders and pay, but last out of 60 million we have paid, we get 5 million, not 1 million. So, what are you doing about your children for PMNS?
Thank you so much from Samburu. A last one. A burning last one. So I will allow any pharmacist can tackle the first one on the community pharmacy. On the inclusion of the community pharmacy for getting the data to, yeah, and maybe giving them a code.
Okay. Can I come first?
Yes, yes.
Yeah, in Homa Bay, we are no longer supplying community pharmacists with the program-supported family planning. The reason was data issue, and also there was no clear methodology on how they'll be offering these services. Because if the partner, the donor supports a program to be, the commodity to be issued free of charge, and they start selling it, it's like you are funding a private entity. So it becomes an issue of accountability. So in Homa Bay, we only supply, at the moment, we supply only public health facilities, and they are accessible to all people. So in the month of, was it June or July, when we talked about this issue of private pharmacies, because they were resisting to give data, and they were selling commodities at higher prices. So it becomes an issue of accountability. So we are no longer supplying them. But what I can say is that we are well structured as a county in Homa Bay to ensure these commodities are accessible to any person in need of them. Because when you talk of any person, we mean both men and women. Men need condoms, women may need condoms with others. So we make sure it's available. So the most important point is to make it available and accessible and affordable. So it should be free at the moment. Thank you.
Thank you so much. Any county with a different scenario? Another blow on the total market approach? Garrett, do you have a different one from?
Yeah. Okay, for Narok, also we don't supply community pharmacies with FP commodities, and the reasons are the same. We don't get that data, and again, there is no policy towards the same of supplying these FP commodities to private pharmacies. Private facilities we do supply, but they report as a satellite site to a government facility. So we get the data from the private facilities. They are verified, they are vetted by the sub-counties before they are included in the system.
Thank you so much. You can respond to the questions directed to KEMSA.
Okay, I'm going to respond in the what we are doing as KEMSA to ensure there are no national stockouts. Mostly, as I said before, we are focusing on the data that is being provided to us in terms of quantification, and even when we are purchasing commodities, we are currently using the algorithm that the system gives us in terms of consumption data. And then in terms of the EMMS orders, I'm not versed in that, but my colleague is online. He can reply to you maybe at a later time. Thank you.
Yeah, thank you so much. We'll be linking you to Dr. Dennis. Do you have anybody from the national government, Ambule, who can tell us what they are doing with the El Nino affected counties? Anybody from the national government who can tell us what they are doing now with the El Nino rains? Or any county that wants to tell us what they are doing very quickly as we close? Any county that is experiencing this first line El Nino thing and you want to share what you are doing with the commodities?
If I can answer that in terms of KEMSA, during the El Nino, we had a meeting last week with the CECs of health and finance, and we agreed that they should give us a leeway on maybe opening the facilities during weekends. So whenever the commodities are in transit, even if they delay, the facilities should be able to receive the commodities on weekends and even at later times past 5 p.m. Yes, those are some of the agreements. I can see Hambule has come.
Ambule, how are you? Sorry about this. Is there anything special that you're putting in place to make sure that family planning commodities are reaching the last mile during the El Nino rains? Sorry about this.
Good morning.
Good morning, Ambule.
The main rains are not expected. However, we have strategies that are in pilot at the moment. We see counties that are addressed drone or broken. Or in one of the counties last week, we witnessed the portion of molecules especially in my district. Problem lying is partnership with the growth company. However, at the moment, we are not going forward for we are thinking in that direction.
Thank you so much, Ambule. I think time is up. Thank you so much for that response. And I'll just maybe give the 5 key points which have come out from this discussion. Then I believe that will be your parting shot. So number one, we've realized there are a lot of innovations which are going on, and especially the LMIS from KEMSA. And now we can at least order stocks you've seen from Teresia, the stock management, and at a click of a button, you can view where stocks are. So that is a very good way of accounting, and at least to make sure that we have our stocks. The other thing which is very clear from this discussion is the data issues. How are we going to tackle data from our counties, right from the facility? Because if we miss it at the source document, then we miss it all. There has been revision of tools. Has dissemination been done? Are we capturing this? Are we really disseminating also to the right people? Or you are getting a nurse working in casualty to come and be disseminated to, then she goes back to the wrong placement. I'm sure at facility level, we are going to check that. The other thing was the real commodity delivering and also the financing. Yesterday's talks, there was a lot of talking of 2026. Most of the development partners, including FCD or UNFPA from the talk in the morning, in 2026, we are not expecting any more funding. How much are we doing our domestic funding? Is it ring-fenced? And is it something that we are sure of by now? This is something now we should be seen to be making efforts as counties to make sure that we get our own domestic financing and very well ring-fenced. We did a case for investment with the UNFPA, and I'm sure it is somewhere in Parliament or somewhere. It's at a very high level, so I hope it will bring out some insights on the same direction. About the last mile distribution, at least Ambule has said, especially with these eventualities and catastrophes, now we see the government is at least putting in something in place to ensure that not only the commodities but services are taking place. And especially now that we are also getting key populations of the displacement, you remember displacement has its own unique needs. So we hope that is in place. And that is it from us. We really do appreciate. Thank you so much.
Thank you so much. These are very fun. And as we do that, again, the department of one,
Thank you.
Thank you.
attention, everyone. Thank you. Our next session will be on planning, financing, and coordination of family planning. It will be moderated by Dr. Charles Aurora. So let's appreciate Charles as he comes.
Thank you. Good afternoon, good morning. All protocols observed. I'm going to take you through the session, planning, financing, and coordination of family planning. And we are going to start with an overview of what we have done. Then at a later stage, we are going to break into round table discussions. And whereby we will, at a later stage, we will have representation from some of the geographical locations to help us sum up the key discussion points. So the title of the session is Planning, Financing, and Coordination of Family Planning. The presenters, Charles Aurora, myself, and supported by James Commander. This is in line with our fourth output and our key discussion questions. The first question is, how can counties enhance family planning, enhance planning, financing, and coordination of FP matters? Then what can we do better? By doing better, what are the best practices that we need to share at this forum and on them? Then how can we achieve sustainability? We all know that working out something at our level best is not really a big task, but sustaining it, making it a norm is one of the challenges. So we need to ensure that we sustain the best practices. So I'm going to take you through some of the achievements we have achieved as a Desip program for the years we have been working. The first one is we have supported review, development, launch, and dissemination of RH-related policy documents, some at national, some at county level. Then the second one is supported and participated in the national and county technical working groups meetings. And these are one of the key accountability forums we have. The other one is supported and participated both in CIDPs. CIDP is County Integrated Development Plans, which are a master plan of what needs to be done in the given counties, and it gives insights to resource allocation. And having in mind that our key discussion point here is planning and financing, so CIDPs are one of the key roadmaps to financing, family planning, and then annual work plans at county level. Then we have support for FP commodity security through review of FP dashboards. And some of these points were discussed by our previous moderators, that's Charles Ngatia and Lydia Ndungu. Then under this subsection, we also need to look at demand creation, effective community engagement. That's across all the tiers, and it was extensively discussed. Now what we need to put together is how to sustain it under planning of FP services. Then we have other key strategic parts that we need to look into is multi-sectorial collaboration and enabling environment. We all understand that for the success of family planning, no no partner, no entity that can work alone. We need, then what we have achieved so far is the development of county-specific investment cases. The other one is building capacity of counties for advocacy and accountability. We have also supported, and participated into FIF bills. These are facility improvement fund bills, how to ensure that resources generated from given facilities are retained and are used in those specific facilities to enhance service delivery. Then supporting commemoration of World Health Days. This is done also to ensure that advocacy is done across the socio-ecological framework such that all parties are aware of what needs to be done. Now, what we're going to do, these are some of the policies we have supported. The Kenya Family Planning Costed Implementation Plan, National Family Planning Standards for Healthcare. We have National Reproductive Health Family Planning Commodity Security Strategy. We have the Total Market Approach for Family Planning National Strategy, which was extensively discussed in the earlier session. We also have others like the National DMP Trainers Manual, Post-Pregnancy Family Planning Training. Then we have Post-Pregnancy Family Planning, the second module. Then we have others that are county-specific. Yesterday, it was mentioned that we also supported reproductive health, social behavior change, communication strategies, among others. At this point, for interest of time, we will go straight to roundtable discussions, and to make the logistics and settling time ample, we will request team members, the ones that are few, the team members, the delegates who are seated 2 or 3, kindly I request you to join the next tables. You fill them. Then under those tables, kindly nominate a rapporteur and a chairperson. And we will have a 20 minutes discussion. Our key discussion questions are these 3. The first one, allow me to re-emphasize, how can counties enhance planning, financing, and coordination of FP matters? And top-notch best practices, the unique things that we need to do to ensure that we are on track, and what aspects of these can we improve. Then the last part, which is key for this forum, how can we ensure that we achieve sustainability? I don't want to preempt some of the discussion points. I leave them at your liberty as delegates to discuss. So I allow 5 minutes for movement and the team to reconstitute, such that they pick a rapporteur of their choice and a chairperson to coordinate the discussion. And at a later stage, after 20 minutes, we will have some few representations coming to give us the key highlights before we move to the next steps. Kamande karibu.
Okay, Edwin, can we appreciate Charles for his presentation?
We can do better than that, guys. Let's appreciate Charles for that amazing presentation, even as we wind that up. Then, as he requested, we can move to the tables. If you're seated alone or in twos, you can fill a table that has, extra seats. so that then you can have that round table discussion. So let's do that even as the DJ plays some soft music.
Okay, I think Charles is moving us to the next very short session. Charles, I think you can tell us how to go about it.
You've only got one mama, you've only got one pa, you've only got one life to live, no matter who you are. You can go the whole world over, every city has its dawn, but everybody living has one place where he was born. And mine is Kenya, so warm and wild and free. You'll always stay with me here in my heart. My land is Kenya, right from your highlands to the sea. You'll always stay with me here in my heart. You've only got one child, and the memory that springs when you see your house, the tree you climb, all those precious things, the faces of the friends I had, the images that fall. When I close my eyes in the land I love, the land where I was born.
Hello. Let us wrap up in 5 minutes' time. Hello, we need to wind up.
Am I audible on this one? Great. Thank you so much for the discussions that are going on. I know we would all ask for more time to keep sharing our insights, but we are cognizant of time and we'd like to finish as we promised. So allow me to take back this discussion back to Dr. Charles Aurora here. This is the format that we will take. We have our ushers who are going around the tables. And with your consent, when they get to your table, they'll either take a photo of your deliberations or the paper that you wrote it on for the purpose of us collating everything internally. However, we'll give a chance to 3 tables to one person per table for 3 regions so that they can represent the views of everybody. Are we agreed? Yes? I want to feel like I have everybody's attention. I don't yet. If you can hear me, look at me. Then I'll know I have your attention. If you're not looking at me, you didn't hear me. I have 40% attention. I have 55. I still have 55. 65. Perfect. I have 70% on account of Irene's table. Looking at me, everyone, so that we summarize this session. Okay, I'm at 88%. I'm looking for 90% because this is public health programming. All right. Okay, I'm at 90%. Charles.
Thank you, Dr. Pai. And we're going to start with some representation, and that will be random. So we will do it randomly through clusters. And at this point, I will welcome Toroitich Chesang to help us summarize what they have discussed, and kindly take a maximum of 5 minutes. And after Toroitich Chesang, we will have Kenneth Miriti, County Programs Coordinator, Kilifi County, to be the second one. And the third person will be Alex Mungai, County Pharmacist, Samburu County. Thank you. Karibu.
So for our table, for question number 1, how can the counties enhance planning, financing, and coordination of family planning matters? We came up with the following ideas. 1, we needed to conduct high-level advocacy, targeting the county leadership for allocation and availing or disbursement of family planning activities. We need also to entrench family planning activities in our county implementation development plan, annual work plan, and any other policy document available. Number 3, we needed to disseminate all family planning national policy documents to the last mile or to the lowest level. We have just seen many documents that have been developed nationally, and we are not sure whether our healthcare providers and our community members are really aware of those documents. For question number 2 about what we can do better, we have come up with a few ideas. 1, advocate for family planning budget lines and ring-fence those funds. Number 2, strengthen and participate in stakeholder engagement, especially public participation, for the community to stand up and really rally the county leadership and in the wards for allocation of funds and resources, especially now that we have ward fund at the community level. Finally, social accountability. We really want our communities to be able to voice their concerns and their ideas as far as child spacing is concerned. For number 3, how can we achieve sustainability in planning, financing, and coordination of family planning? Number 1, we need to actualize domestic financing for family planning. Number 2, advocate for program-based budget where when funds are being allocated in our counties, we know how much has been allocated for family planning specifically. 3, integration of services. We cannot afford to offer services in silos. We need to make sure that we integrate our services. Enhance and strengthen data quality and quality improvement teams as far as family planning is concerned. Capacity building, strengthen our technical working groups, that is the commodity and reproductive, maternal, neonatal and child and adolescent health, and any other technical working group. Strengthen primary health care, community health services, and of importance is to align family planning to primary care network. Thank you so much. And I hand over.
Thank you, Torotich. Next is Kenneth Miritik from Kilifi. Karibu Daktari.
Good afternoon. So the time was not very friendly for us, but we have come up. First, planning and financing of family planning. So how we said we are going to divide it into the how, what can we do, and what are the best practices, what is the sustainability plan. And the first thing we have said is demand creation, multi-sectoral approaches. Then how can counties enhance planning and financing of family planning? And we have said the first one is prioritize FP in the health sector's plans, that's budgets, and look for gray areas where budgets have been lump summed. We know very well that most counties, family planning budgets are put under the RAMCA budget, the preventive promotive, so we need to tease out areas that family planning activities have been highlighted. And then number 3, we lobby for and provide provision for IFMIS and FP code. We know that is something hard, but it's, as we continue with the advocacy, probably we can get that so that we can have a code specifically for family planning in IFMIS, and that will help us to ring fence money that is supposed to be allocated for family planning. And then strategically develop action plan on utilization of family planning budgets in the preventive services. That is preventive. In promotive, we have demand creation, and in curative, we have service uptake and commodity access. And then what can we do better? First, we have said we develop effective annual work plans, monitoring and tracking of implementation of annual work plans. Most of us in the counties know very well that that's the area that we are able to access the funds. When we put them in the annual work plans, we're able to get the finance people, the accounting officers in the counties able to give us the money to do the activities. And then involve departments, that is the Department of Finance, Department of Planning and Budgeting in everything that we do. Those are people that we have ignored sometimes for a long time, and these are guys who can help us actually to be able to get what we want in terms of the budgeting. Because at the end of the day, we don't take part in budgeting, all of us. So they need to understand so that they're able to help us to lobby and also make others understand what we want for family planning. Then number 2 is the effective costing of family planning, and this is having a robust health economics in various counties. I was mentioning in our county we have like 3 health economists who are helping us so much in terms of costing. Then costing for all activities, GOK sponsored and partner sponsored. We were mentioning about partners under the carpet budgets, where you display a lot of activities that you are doing in the counties, but you don't tell us how much money they are costing. So at the end of the day, what happens? When you leave, we are left scampering how much money was being used for this activity. So we are imploring, especially on the Desip program, that we need to understand the budget. It doesn't cost you anything. We won't encroach into your budgets when you share with us the budget. So that at the end of the day, every year we are able to know how much money we are using for family planning program within a given county, whether it is in terms of activities, in terms of commodities, in terms of demand creation, all those activities can be able to be costed. Then number 4, conducting county FP assessment needs, very important for the counties, and also capacity building FP program persons within the county. We are lacking capacity in terms of programming within the county. So that you realize an M&D from Desip, from PS Kenya, is than the M&D at the county level. When you look at the quality of work and what is coming from their mouths, we need to have the same level, and this is something that needs to come up in even when partners are doing their program activities. Let us then empower, because at the end of the program, the person that you leave behind is that person who is not empowered. The other thing we have talked about is best practices. First of all, development of service delivery models within specific counties, and that cannot come if you don't have empowered program persons within the counties. If they have the same mentality of the old age, then definitely we will not have these things coming. Then education, that is awareness, long-term solutions, promotion of products. For example, at UCD, I was actually mentioning in the group that when the team here for total market approach were doing their presentation, a big question was coming to me in terms of the people that are producing this, that is the manufacturers of these products. We are not seeing any marketing of those commodities in public. You have left it to healthcare providers to tell people who are coming to seek for services, instead of them understanding from outside that we have IUCD, we have this kind of a method. We are not seeing those things on television, coming before the news, for example, telling people that these commodities are available within the pharmacies, within the health facilities. So we were talking about that we need to market as much as possible so that people can take up the methods. Then education, education, awareness, that is the long-term solutions for family planning in terms of either financing or even marketing. Promotion of products and technology use. The use of technology is very important. Kenyans nowadays are in X a lot, are in LinkedIn, are in Facebook, are in TikTok. So we need to have this as one of the activities that is able to help us be able to give information, spread a lot of information in a very short time and to a very big mass of people. And finally, stakeholder engagement, that is inclusion of other actors that we have not brought on board in family planning. Who are these people I'm talking about? They have come here. We have the religious leaders. They are marvelous people in terms of bringing in and also actually changing behavior within their churches and the mosques. We have the young people. We also have the department, the county departments, especially the Department of Gender, Culture and Social Services. Very important. And finally, the Department of Children. And I'm saying this because I'm one of the people that are saying that we cannot deny family planning for adolescents, especially those who are already sexually active, those who have already started giving birth. We cannot give them half antenatal care services. We have to give them holistic antenatal care services. I hope the national team is here so that they also invite us to those technical working groups and we change the narrative that is out there, that an adolescent who has become pregnant cannot get family planning services. They can only get family planning services when they come with their mothers. But they never went, my final shot, these adolescents never went with their parents to get pregnant. They did not seek for that authorization to get pregnant. Please let us not deny them services. Thank you.
Thank you. We will have the last presentation from Dr. Alex Mungai, County Pharmacist, Samburu County. And after that, our team members have been collecting the views you generated. We will incorporate them. Kindly forgive us. Time. Karibu Daktari.
Thank you. Good afternoon. For my region, which I think I'm representing the arid regions, we're looking at the planning. Of course, we start with the AWP, which fits into the CIDP, but we make it smart, especially with regards to our FP indicators. And then this will feed into the family planning costed implementation plan. And with that plan, we're we're saying that we're going to sensitize the county health executives, that's the CECs and the chief officers, who we in turn will go and sensitize the county assembly health committee. Of course, there's the chairman of the health committee, who's in our case is a healthcare worker. We make them a champion for our cause. At the same time, it's very important also to sensitize the county health finance and procurement committee, so as to get the buy-in from those two committees, who in turn will sensitize the county assembly with our objectives. And we were saying as a group in our discussion that as much as we are messaging to the county assembly, we want to make it more personalized, whereby now we break down the data per ward level. And the messaging has to be very key in this case. So the correct messaging about child spacing, we are looking at the key, identifying politically correct messaging, or politically correct indicators. In this case, we can talk about reducing maternal deaths, reducing child mortality, which will resonate with the political leadership in this case. Then we were also still in the planning, we are talking about an MOU between the county government, the Ministry of Health, and the partners. And in this case, it's with regards to FP implementation, and we're also looking at a roadmap to sustainability. If in the first year talking about 0% and the partners are doing 100%, second year 25%, county does 75%, at the end of the day, it's the county government which will do 100%, partners 0%. I believe that's what we want. So that's one idea that we have. With regards to financing, the FIF bills need to be developed. In some cases they are. And in some of our counties, we need to ring-fence the funds for the procurement of FP commodities. And also, with each county has a health products and technology unit. In this case, we want to anchor the HPTU into the health bill so as to drive the agenda going forward with regards to FP matters. Then we also talked about forecasting and quantification for FP, but this will be now at the sub-county level down to the ward level. We try and personalize the message as much for the politicians as we can, so they can actually visualize, because the challenge we have with most of these politicians, they cannot see. We just go and talk about percentages and they will not understand what you're saying. But the moment you put a map with red, green, yellow, they'll be like, why is that red? Why is that yellow? I don't want to be red, I want to be green. So we realize that really resonates well with them, and we just make sure that they speak our language and we get the buy-in eventually. Then we're also talking about budget tracking, because every year we do plan for FP procurement and activities, but the money goes into our pot and disappears. So the question is, can we start now doing budget tracking of the FP funds to ensure utilization of these funds? And that one can be done with the health committee of the county assembly as well as the executive for health. When you look at sustainability, the joint work plans, which we have at the county level, we can have joint work plans with the partners as well, so we can synchronize our activities. And after we have finalized formulation of these plans, then we can then share with the health executive, who in turn will share with the governor and the other leaders in the county, so as to get their buy-in and to understand why it is that we want to do what we want to do. And also on coordination, we're looking at using the existing structures in the county, in this case the Health Products and Technology Unit, working together the CHMT, County Health Management Team, as well as the sub-county health management teams. We can be having FP, technical working groups in the sub-counties at a monthly basis or quarterly, and one quarterly county health management TWG on FP. Show us to support and strengthen the activities going forward. Then we're also looking at, still on sustainability, on data-driven activities. As the data, if we mine the data correctly, you can actually see which facilities are doing well, which ones are not doing so well, which ones are doing poorly. And instead of just doing supervision which is not targeted, we can actually target facilities which are performing poorly. And we have done that in some cases, and it helps improve the indicators of these facilities. And we focus on the data quality. We look at if maybe the in charge requires mentorship or JT, just simple, basic things that can help improve the indicators and improve the data quality going forward, as well as CMEs, regular CMEs, which are sustainable at the health facility level. And we make them as frequently as possible, as well as dissemination of the policy guidelines of the national government going forward. So I think that's my presentation. Thank you.
Thank you, Daktari. For the spirit of social inclusion, we have one of our champions who will say something. Emily, karibu.
Can you clap for me for being the only driving class in the conference? Okay. Thank you so much for that clap. Now, my name is Emily. You know, when you talk last, you talk nothing. So, but I'll have something to add. Now, question number 1. I think by trying to engage PWDs, where we represent ourselves, comment, by coming up with the disability mainstreaming policies, and that will really help in allocating for the services that we need. And you know, PWDs don't have so many issues, but by even engaging us as individuals to go and empower the community, isn't it? So I'm also here. Well, last but not least, I want to thank everyone who has made this day a success for us. As I have said, my name is Emily Juma. I'm the director for Amazing Group of PWDs. It is a CBO, and I'm the one who came with a team who did a skit yesterday. Can you clap for me once again? So I want to thank Dr. Jenga. You have a good team, and thank you so much for remembering us, Kama PWDs. I really appreciate. My special thanks also go for the Desip, Dr. Jinaki Ningumu, and to Apache, that beautiful lady. Thank you so much. And to the entire Desip team. You know I'm talking last because I'm going. Can we clap for them? Last but not least, I want to appreciate our team from Mombasa. Kwanza ningependa kushukuru Jennifer. I don't know whether she's in the house. Jennifer. So can you clap for that beautiful lady? You know, I didn't know so much about family planning, but when I was introduced to Jennifer, I remember imagining Emily on a wheelchair and calling a lady passing, "Excuse me, my name is Emily. I want to talk to you about family planning." And she's like, "Hey, what is this woman on a wheelchair telling me?" And I'm like, "No, I'm doing family planning." And people were coming, even those who don't have disability. Can you clap for her again? So thank you so much for doing disability mainstreaming, for making the community feel that even if we have special needs, we can also lead, isn't it? And nikimalizia, I'm finishing. I want to thank Mr. Kimeo, Dr. Sylvester. Should I call him doctor? You know, as CHVs, we are normally called doctors, even if you don't have that profession. So thank you so much, Dr. Kwapi. Yeah, this guy, okay, when you see us performing here, he has been crossing almost every day, coming to Likoni, to make sure that we are giving you the fine product. So thank you so much, sir. We don't take your efforts for granted. And nikimalizia, all our media, all our participants, which I could call you by names, but can you clap for yourself if you are in this house? Now, sasa, to my team from Mombasa, can you wave to the team? So thank you so much for giving me the easiest time. Mimi, I love you so much. When you are in Likoni, just come. I can host you, but you will sleep outside because you are mean. I love you. I really have a big heart. So we also welcome networking. We don't have funds, by the way. but we have a physical office. So when you are in Likoni or you are in Mombasa, I'm just a phone call away. You can just call me. When you call Jennifer, I'm available for free. Thank you.
Thank you, Emily, for that. Now we go to the next session, question and answers, which will take us around 5 or 6 minutes before we close this session. And the key questions will be directed to the the 4 presenters who are here. Thank you. Any question? And you can name the facilitator, the person who presented the session, if any. If none, Commander, you can lead this session to applause all those who have facilitated and all the participants for the group discussion, the roundtable discussion. Thank you, Commander.
Okay, Edwin, could you please help us appreciating Dr. Charles Aurora and the team, and also Emily for that session?
All right, thank you. So for Charles, we'll do the clap, clap, snap, snap, and stamp, stamp. All right, do you remember that? Do we remember? So let's try. Clap, clap, snap, snap, stamp, stamp. Clap, clap, snap, snap, stamp, stamp. Then for the team, we do the thunderstorm one more time. So warm your hands, warm your hands, warm your hands, warm your hands. Warm your hands for that amazing team for the presentations, representing the different teams as well. Let's start clapping, let's start clapping, let's start clapping, let's start clapping. Let's clap, let's clap, let's clap, let's clap, let's clap, let's go, 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 let's go. Let's go one more time, go! All right, good stuff. Commander, with your permission, if I can just do an activity, then we proceed to the next segment. 2 minutes. So I want to divide the audience into 3. These 4 tables will be the people, all right? Then these 3 from here to here will be the police, all right? Then the last tables, allow me to call you the thieves. All right? I have the permission? Okay. So when I say the people, I want the people to stand and sit. When I say the police, I want the police to stand and sit. When I say the thieves, I want the thieves to stand and sit. Easy? Let's try thieves. Yeah. Police, people. So I will tell a story. This story has those categories of people. When you hear the people being mentioned, just stand and sit, right? So once upon a time were the people. And the people were afraid of the thieves because the thieves were stealing from the people. So the people decided to report the thieves to the police. And little did they know that the police and the thieves were one big family. The thieves and the police were brothers and sisters to the people. And so the people decided to take action in their hands and approach the thieves together with the police. Thank you, ladies and gentlemen. MC Commander.
Let's appreciate Edwin. Thank you so much, Edwin. Our next session is going to be moderated by Peris Waithaka. Peris Waithaka is a program manager working with PS Kenya A360 program. Karibu sana, Peris. And as you can see, even the podium is transitioning. So it means Peris has something nicer to tell us. Karibu sana.
Thank you. Thank you, James. We are a big team, so as they set up. So this podium is giving me some preaching vibes. So turn to your neighbor and tell them mission time. You haven't smiled. Turn to your neighbor and smile. So I have my co-host.
My name is Michael Mugo. I'm a business advisor for the social enterprise within PS Kenya. I part of the team that is championing on the digital innovations in PS Kenya, such like the Saramed HMIS. We have Dawa Pool, which is coming up and hitting the market very soon. Thank you.
Thank you. So, ladies and gentlemen, Desip is currently in its 5th year. It's been a journey. For some of the people who started Desip, like Josephine and the rest, know that it's been a journey. From receiving the grant and the excitement that comes with it. And you're excited and you know that the work has just started. To a lot of county engagement, county entry meetings, co-creation sessions, and the actual implementation, a lot of work. You can agree with me, especially the program staff. It's been tough. But today, we are here to celebrate some of the achievements. A lot has been achieved. We've seen counties recording improved MCPR. We've seen behavior change within the communities. We've seen a lot of achievement. And so behind the success is unwavering support from individuals, organizations, and governments. And I mean county government. Organizations, I mean National Council for Population Development, National Council for Persons with Disabilities, and many others. And so this afternoon, we are honored, I and my co-host, Mr. Mugo, we are honored to stand here and acknowledge the achievements of the brilliant efforts towards accelerating the shift in FP. You can agree there has been some shift. So we will not only recognize and reward the immense contribution and support given to the Desip program, but we'll also give due regard to the value propositions the awardees exemplified, like dedication, a lot of commitment, and zeal to ensure that every woman has access to information and quality FP services. To each and everyone present in the room, to every person who in one way or the other supported the program, we say you are the winners. So again, in the spirit of preaching, turn to your neighbor and tell them you are the winner. I am the winner. To those of you who will be receiving the recognition and the appreciation in different categories, we say well done and keep the great work ongoing. And so, we will award the counties, the facilities within the counties, the CHVs, and the CBOs, and the champion individuals who supported mainstreaming disability, inclusion as part of FP and reproductive health services, ensuring no one is left behind.
Right, before we get to the next category, I'm seeing a lot of gloomy faces. Guys, it's celebration time. We've done the work. We're here to celebrate. We're here to recognize everyone. So DJ, cue music for celebration. Let's shut the laptops for like 5 minutes. Thank you, thank you. Right. Did you introduce the first category? Yeah. So the first category is on mainstreaming disability inclusion. We'll start with the counties. The 3 counties that are being awarded here are Homa Bay. Hey, DJ, come on. Narok. So that is Mombasa County. Narok County next.
staff supporting Homa Bay, you're supposed to be upstanding because you work as a team. So the program staff from the consortium supporting Homa Bay County.
You can be left behind because there's still another subcategory that will involve you. Say something?
Sure. So Team Narok and Team
But within those counties, there are those facilities that really did the job and they exceeded expectations. And these three facilities are Homa Bay County Referral Teaching and Referral Hospital, sorry for that. We have Transmara West Sub-County Hospital and Watamu Community in Kilifi County. Please, representatives of these three institutions. Those that really helped with the numbers. And these three CBO groups are amazing group of persons with disabilities in Mombasa County. We have Narok County Youth Council Network and County Youth and Adolescent Network in Homa Bay. So representative of these institutions again, welcome on board. Category, we are going to call the first Desip project lead, be Josephine Biu. Kindly welcome here. Homa Bay team, well done, well done. Let's give them a hearty clap. To come on, join her on here.
Thank you, Josephine. It is, sorry for the confusion, it is James Kamande awarding the next.
Sorry for that.
Next category.
Next awardee is Narok County Youth Council Network. Youth Council Network. Youth and Adolescent Network in Homa Bay. Category, the first, to help us with this award, we are going to invite Dennis Mugambi from VSO. Dennis, are you here with us? Dennis? Janet Bonareri. Janet. Sang Torotich. And last but not least, we have Rael Agitu.
I'm told he's saying congratulations, and this is a very beautiful award. So in that spirit, we are going to celebrate in the sign language. You know how to do that, eh? You're going to do? So let's celebrate. Thank you. Thank you, Dennis. So the next category is some religious leaders that supported, address the barriers that often impede the uptake of contraceptives. And they did a lot. We even had churches that were supporting outreaches, announcement of outreaches through their churches. And they did a lot in awareness creation. So today, we recognize them.
Thank you. The first awardees in this category, Reverend Githumu Munyambu. Let's clap. Category, we are going to call upon. He already has a preference of who he wants to be given with. Gerald Gidinji from Hera Consultancy, kindly come and help us issue this award. We also have one posthumous recognition for Reverend Grace Ngodho, who really helped in fighting the barriers for religious barriers. So I will kindly request everyone that we be upstanding and we observe 1 minute applause for the work that Reverend Grace did in Desip. Thank you very much.
Thank you, Gerald. So we will recognize counties and champions who supported community-based distribution to delivering family planning to women of reproductive age. So they used to move village to village, and we did consider those who used to do very good reporting and ensuring that this report is captured in the KHIS. And they did support women, especially from marginalized and hard-to-reach areas. So Mogo, give us the counties.
Thank you. Just before I go to the counties, to help us in this category, I'm kindly requesting Hambule Mohammed to join us on podium to issue the awardees. As he comes over, the counties are Narok County, champions in the same category.
And Mugo, Mugo, I'm reminded that you give them time to dance. A second
I am
to
sorry,
dance.
I'm cutting the enjoyment.
Exactly.
I am so sorry. I will not do it again. The champions are within the same category. Joseph Nganga, Baringo County. Kibicho from Isiolo County. Christopher Chemwon from Narok County. From West Pokot. We'll start with Isiolo. I can hold this for you. Can do much better. Let's give them a hearty clap. Next we have West Pokot. Baringo County next. And lastly, we have Narok who are getting a certificate under Sarah Plague.
The next category we will be assisted by Alex Omari from FP 2030.
On behalf? Yeah, you can take on behalf. Chemngon from Narok County. Taking on behalf. Kaibos from West Pokot. Thank you.
Counties and champions supported the MAD creation initiative of the male engagement to promote uptake of the family planning. Who will give us the counties and the champions?
The counties that have been are receiving an award under this category are Narok County, help us in awarding this category. Do you have any representative from NCPD? Anyone from NCPD? Champions under the same category are Akiru Tomele, their behalf, the county. Joseph Sirikwa from Narok. Alex Leleina from Samburu. Samburu, who's taking for Samburu? we have Narok, who are also getting a plaque for their work. Very much. Thank you. Thank you. Champions, we have Jennifer Gakure. Jennifer, please come on board. Yes. You thought I would not call you? Yes, it's you. We have Alex Lelena. Clap again. Hearty, hearty clap as we close that session. Thank you. Thank you so much, Jennifer.
Thank you. So let me go back to the podium because I've
Please
seen
take over.
you.
Yeah. You've seen how much fun I'm having on this side.
Yes.
So can I go on that side?
Please do.
So.
Go the other side. So the next counties and champions are supported structured on-job training and mentorship model for increasing long-term service delivery. So we have counties and we have champions.
The counties under this category are Baringo County, next is Narok County, lastly, we have Homa Bay County. In awarding this category, I call upon Peter Ofware to come and help us give us the awards. Thank you so much, sir. Same category. In this subcategory, we are recognizing Anchebi. Anchebi.
Can receive on their behalf. Baringo County.
The person we are also recognizing in this category is Brighton Otudo. In home in the same subcategory, we are also recognizing Elizabeth Naikumi from Narok. County can take on behalf. Elizabeth, thank you so much.
We will have Collins Mushoki, FPRH coordinator from PS Kenya. We are now recognizing the counties that recorded lowest teenage pregnancies. There are 3 counties, and Mogo will give us the counties.
The counties that recorded the least teenage pregnancies are number 1, Wajir County. County, Mombasa County. Have Kilifi County. Firstly, we have Wajir.
Thank you. So the next category is the best performing among Desip counties in MCPR, modern contraceptive prevalence rates, among the 12 Desip counties, and Mugo will give us the counties that did well according to KDHS 2022.
The counties that did well under this category are Elgeyo Marakwet, the next county is Kajiado County. If no one from Kajiado is here, program team, please. This is also your effort. Grace Kanyoro, where are you? County.
You can pick on behalf of Migori. To recognize the counties that did exemplary well, we will have Dr. Margaret Jenga, CEO, PS Kenya, award the counties that did well in modern contraceptive prevalence rate. Margaret, I don't know why I'm told that there needs to be some dance as you went because you never danced as you came. I don't know why for this specific one. So music. So the next category is about the most improved in matters of modern contraceptive prevalence rate among the 12 Desip counties. Please note that we are talking about the Desip counties, not the entire country. So we have 3 counties that did improve matters of MCPR.
The counties that improved the most are Elgeyo Marakwet, Baringo County, Narok County.
Has recognized these counties. DJ, please look for some nice coastal music for Dr. Pahe. To us. So good music.
Go back, go back, go back. Until the DJ cues the music.
So the last indicator in the last category is the counties with lowest unmet need for FP among the Desip supported counties, and there are 3 counties.
The counties that had the lowest unmet need are: number 1, Wajir County. We have Kajiado County. Risa County.
Thank you. So DJ, look for some nice Kalenjin song for Dr. Rotich to
Check
come
it.
and support us.
Check it. awardee and who's being awarded. This guy is having too much fun.
Someone is testing our patience that before we leave here, we must also dance. Remember, we are the bosses here, so we are the people who are commanding.
What have we just been doing, Bwana?
Exactly.
Ni podium inatuzuia. You can't see us. We are dancing.
But okay, we are up to the challenge. So we are going to award 12 individuals who contributed in strengthening documentation for Desip program work through abstract submission. And because of time, I request that they come very, very quickly. Give us the names of the 12 individuals. Mogo.
Forgive me for killing anybody's name. This is a test of my tongue. Francisca Akope. Ochora. Molly Ochora. Francis Kiao. Lennox Kenywa. Dr. Alex Mungai. Hussein Somo. Juma. And Irene Olale. Hearty clap as they come on board.
Jeffrey Okumu from Options. Kindly come and assist us. we are now giving out certificates of appreciation for support towards Desip work. And the first to receive that certificate is the national team, Ministry of Health, Department of Reproductive and Maternal Health. I will request Akacho from FCDO to come and present that certificate to the DRMH, the Department of Reproductive and Maternal Health. I have to see you after so that you tell us why are you putting some gospel music to some and other music to other presenters. We will see you after this. So the next organization to receive certificate of appreciation for supporting Desip work is KEMSA, and I will request Lawrence Matenjo to come and give KEMSA that certificate. Organization receiving the certificate of appreciation is National Council for Population Development, and I request Mutai from PSI to come and give that certificate.
Multi-agencies. It was not only PS Kenya. We collaborated with a lot of agencies and organizations, and this time we want to also recognize their efforts in having such a successful program. Firstly, we are going to call Voluntary Services Overseas. Yes, institution you're calling is, or do we give one by one? No, let's call. All right. Faith to Action Network. Faith to Action Network. International. Africa. This is Kenya. Options. Population Services International.
Consortium gave to the Desip program, it is only fair that FCDO awards these organizations. So Akacho. The next certificate of appreciation is to all the counties that are currently supporting DESI program, the 12 counties. So Mugo will cover us in batches of 3 so that we give them a certificate of appreciation.
The first 3 counties are Baringo County, West Pokot.
In appreciating these counties, we will have Gladys Someren, the former FP.
Homa Bay, Kilifi,
And Koima from National Population for Persons.
You want the mic?
National Council for Persons with Disabilities. Assistants appreciate these 3 counties. John wants to be my former campus mate. So for this one, you have to clap. Nice.
Mombasa County, Mandera County, and Marsabit County. Sorry.
Appreciate these counties. We will have Ken Joroge from PS Kenya appreciating these counties. Ken.
Isiolo County, Samburu County, and Wajir County.
Thombe to come and appreciate these counties.
Don't come in a rush. Don't come in a rush.
Please put.
He's looking for the nice Gamba song.
Let's stand, all of us. All of us. If your neighbor is not standing, please pick their meal voucher because they are not having lunch. Appreciate the person seated next to you and tell them this is your award.
This is your award.
The best award.
The best award.
Maureen, you are not telling anyone that this is the award.
You can tell me. Maureen, you can tell me.
The best award. This is your award.
This is your award.
The best award.
The best award.
Thank you. Now, DJ, you dared us. Give us the music.
Requested to dance ourselves, so who are we? Whom's are we? Other than to dance for you. But please, kindly join us. DJ, cue music as we leave the stage.
Let's have our seats and finalize that session. Wow, that has been wonderful. I didn't know people at PS Kenya are multifaceted, multi-talented. And the people in the FP space are also multi-skilled. So that's been a learning. Give me a minute. I was telling someone I have a child inside of me. You know that self-awareness? And when you play music for more than an hour, I need to give the child inside me time to sit down, otherwise I'll keep dancing. All right, so we've come to the end. I've been asked to do key takeaways. And I'm wondering how to do this. So first, let me allow us to have our closing remarks from 3 representatives. Then I'll wrap it up as we do the vote of thanks. So we'll start with Dr. Margaret from PS Kenya. You can take it from right.
Thank you, Pahe. Good afternoon, everyone. Good afternoon again. It's such a pleasure to be here this afternoon at the end of the Desip conference. This has been amazing, and I just want to appreciate all of you. A big hand to all of us. When we were planning for this conference, first settling on the date was quite difficult. So I know you have left work wherever you are. I just want to acknowledge that and say thank you. Thank you so much for whatever you have posed to be here these 2 days. The engagements have been very intense, very active. There are over 10 conferences happening this week, some globally, some in Kenya, and I sincerely want to appreciate that you found time to join this conference. From the bottom of my heart, those who are still here now and in absentia, those who came yesterday and they left for other commitments. This is the largest forum that brings family planning champions in Kenya together. And indeed, it has been a great 1.5 days. Before I step down, I want to appreciate the PS Kenya team. Please stand from wherever you are. PS Kenya team. This is the planning army for this conference. We didn't have any external suppliers that planned this conference. And they held meetings every day for the last 3 weeks. 2 months. Okay, I was briefed for 3 weeks. You can see the amount of work that really goes on behind the scenes. Thank you so much. Under the leadership of? Jennifer. Of who? Jennifer. Jennifer, thank you for chairing this committee that planned for this conference and for closing all the little pieces. You'll agree with me, there were hardly any hitches in this conference. This is not an easy thing to pull off within such a short time. So thank you so much. I can't fail to acknowledge our development partners, FCDO. Thank you. Thank you very much for making this possible, for giving us the space to be innovative and creative, and for mobilizing as well behind the scenes. Thank you, Akacho and Lawrence, for us. And all our partners who are here. I may not mention you by name because of time, so apologies in advance as I hand over to the next person. Akacho, I hand it over to you. Oh, it's Lawrence, yes. Lawrence, our program manager, thank you for your support. Thank you. A big hand for Lawrence.
I think I'll use the... I won't take too much of your time. In fact, those who know me know I'm a man of few words. So you're in luck. I know you're thinking about lunch. So just allow me to start by introducing myself. My name is Lawrence Matenjwa, and I'm a program manager with the FCDO Human and Social Development team. I'm also part of the team responsible for effective delivery of the Desip program. And I think we can all agree, as Dr. Margaret has mentioned, that the past 1.5 days have been very intense and extremely interesting for all of us. We are very happy that you all managed to come and have stayed for the full conference. As FCDO, we are deeply honored that this learning conference brought together very many stakeholders from across the family planning sector. This was a good opportunity to come together and share experiences, lessons, and best practices from people with diverse expertise from various contexts across the country. Our vision for this conference as FCDO has become a reality with the help of the organizing committee led by PS Kenya. So thank you. I also echo Dr. Margaret's sentiments. We have converged a diverse audience, expert panels with lively and insightful contributions as we reflected on reproductive health and more specifically family planning. From the conversations around the KDHS 2022, the disability inclusion in family planning, to the total market approach and family planning commodity security, we have benefited from diverse views and reflections. We do not want the conversation to end here. We want to continue having these conversations for a long time until we get to where we want to go. So my call to each and every one of you, when you leave here, is to think about how we can practically apply the lessons and best practices that we have discussed and reflected on in this conference, so that we ensure the gains that we have made are sustained. Once again, thank you. And with those few remarks, I hand the mic back over to Dr. Ali.
A hand clap for Lawrence. Thank you so much. Thank you for the support. I've received so much support from the FCDO team behind the scenes. There has been no gap between us. You've been helping us in mobilizing, so thank you very much for the support. I remember conversations I've had with Lawrence where I tell him, so this and this happened, and I was wondering, and then he says, what do you think? And I've never had Adona ask me, what do you think? And I'm like, okay, I thought he was supposed to say, I think. So that was very refreshing. Thank you so much for being approachable, and Akacho as well. I tell you when we're in trouble and you really respond very fast. Thank you so much. So finally, from the MOH, Hambule, who's been with us through the process. He was here with us on Sunday afternoon when we were doing several dry runs, stayed through the session, went through it, perfected it, and yesterday I had him passionately in session B say, I am the father of CBD in this country, and I believe that and I've seen that, so a session team.
Thank you, Dr. Pahe. Good afternoon, ladies and gentlemen. It's a great day, a great afternoon. We've come together since yesterday, celebrating our work, our continued or concerted efforts. Remember, the Ministry of Health is and will continue to be grateful to the continued support of all programs in this country, and today specifically Desip, through the support of FCDO. We appreciate the work. We appreciate the learnings we have seen together. Since yesterday, we've reflected on the following. Probably some of us may remember, we've gone through the overview of Desip as a program. We've talked about the call to action for family planning commitments. Oral presentations have been done on the progress towards FP 2030 goals. We have also discussed around the gains we made reflected in KDHS 2022. We've discussed social inclusion issues, which I think this project has done so very well. We've discussed sustainable approaches. And lastly, we've celebrated together the gains in this FP space. And all this, of course, is from our concerted efforts. Just to pick a few, the most improved counties mentioned here includes Elgeyo Marakwet, Mkoapi. Elgeyo Marakwet, please clap for them. Thank you. Baringo, Narok. I think Narok has been mentioned here until I said, hey, wamekuwa national government. Thank you, Narok, because you realize these three counties have two things in common. Two things. If you may have gone through the sessions yesterday and today, these three counties have two things in common. One of them is they have embraced CBD approach towards reducing the unmet need for family planning. The second thing they share in common is the structured mentorship. And through these probably sustainable approaches, that's why their names have featured in the most improved categories. I was excited also to know that the counties here with the lowest unmet need? Wajia, mko wapi? Wow, thank you very much. Kajiado. Kajiado. Garissa. Thank you very much. And I was asking myself, do they have lowest unmet need really, or maybe they don't have any need for family planning? But that's just on the side. That's on the side. So I'm asking myself, how do we again then use these approaches in the other remaining counties so that we are at par? In our discussions, I want to be short, we have also identified our gaps, our challenges, and most importantly, our opportunities going forward. So after celebrations, what next? Do we just go and say, okay, it's okay now, FP is done? It's actually the start of more and more work. So let's carry home the learnings from this conference and give it a more critical thinking, contextualize it in your own setting, see what approaches can fit your geographies, and eventually, in unmet need, in teenage pregnancies, in MCPR uptake, and eventually we are going to talk about a reduction in maternal and infant mortalities. I want to stop there. Thank you very much, everyone. Desip, FCDO, our other partners who are here, counties, and I have seen a table featuring so well, where probably I'm carrying home something, that social inclusion is something just more than making facilities accessible. It is more than that. It also includes including people with disability in decision-making tables. Thank you very much, and back to you.
Thank you very much. A round of applause for Hambule. Thank you very much, sir. So we have come to the end, and I wouldn't want to repeat what has been mentioned by everybody. Dr. Roshish had put me under pressure. He said, your final key takeaways. And it's been said by everybody, but I thought the thing then to do that puts everything together is measuring. Because then you measure a baseline, then you design a correction, then you measure how well you're doing, then if you're not doing well, you correct, but then you measure your progress, and if you get to skill, you then move. So for me, if I'm taking away one thing, and everything is so important, is the continuous need to measure, so that everything is done based on accurate data, you're designing for the right thing, in the right context, for the right person, and in the right way, and that way you're able to say something. I was saying in the session yesterday that I felt attacked because Lydia, in the session around data, she said, everything you say without data is your opinion. I personally felt attacked. I thought, everything I've ever said, if I didn't say from here to here by metrics, I was lying. Okay. So I would like us to wrap it up by measuring. .36 p.m., the halls were still full. Everyone was here. We did the dance together and moved to the cocktail together. So a round of applause for yourselves, appreciating your participation, your presence. We've really learned a lot from you. And then finally, I'm debating between two things. So we are supposed to do a photo session, and I'd like us to do two things together so that we save time. On the screens, let me have mentimeter.com. Because I appreciate that for every engagement, feedback is so critical. I don't want us to leave it out. So as we'll be coming here for photos, Israel at the back will be running, go to your phone, find Google Chrome on your phone, and then go to mentimeter.com, mter.com. Screens? Great. So I was taught this year, in January of 2023, feedback is a gift. It didn't feel like a gift for the first 6 months, but I had a mindset shift in July, and I said to myself, Pahe, the feedback that you got is a gift. So feedback is going to help us to plan for you better for the next engagements. So as we arrange ourselves, we'll have the first photo session. We'll have development partners, including FCDO, kindly come to the front. Our donors from CIF, FP 2030, NCPD. I will combine development partners and the country directors, so that includes NPI Palladium. Kindly come to the front for the first photo session, and when you're here, stay here, because everybody wants to take a photo with you guys, so don't leave. Donors, I hope I didn't miss anyone out. Any representation from CIF, because I take note that Julie has left, kindly come to the front. And Israel, are we set for the first question? Not yet? Okay. So once you're at mentimeter.com, just wait. Israel will enter, I will demonstrate a code, enter the code, and we'll flash for you very quick questions. Each will take about 30 seconds. Yes. Georgette, I need your help. Yeah. Yes. Informed in our midst, we have Miss County Kenya. So she will join the next session of photos. So the next group, implementing partners. We had a team from In Supply Health. We had different implementing partners supporting us, being present. Kindly join the team on the stage together with Miss County Kenya. Please come. You are a key representation together with me. You and I in the same cohort. Great, thank you. So again, the initial set stays on the stage. And then can I have the county representations, county governments? I really appreciated how each of them sent back a reply and said, Doc will be present. We are aware of the work that Desip has done. We are releasing this officer to be present with you. So all the county leadership, everyone who's received an award today, Elgayo Morocco, please come. Come, this is the group photo we want to demonstrate that we've gotten so much support from the county. I will give this time, so please come, please come. Come to the front, everyone from every county. In fact, this side, I just want to be left with PS Kenya and the IPs, everybody else, this side. Please don't be left behind. We'll send out the photos on email. Everybody from the counties. Photographers a second. Allow the team that's running at the background just to reach there. Anyone from the counties, please don't feel left behind. You're our guests. Photographers a second, please. Allow everybody to move. Give them time. Perfect. The count is perfect. Thank you. Thank you very much. So our key guests remain at the front. So I'd like the CBO members. We had different groups represented from Mombasa. We had a group from Kajiado. Please come. You are our special guests for this session. Please come. Sorry, give him time. We don't have... Sorry, and what about my guests from Coast? Yeah. Oh, I feel like there's... Okay. TBOs, the social inclusion team, please. This is a special advocates. There's Tabby somewhere. Yeah, she's already there. People with the child, those people there. Perfect. For the rest of us, the screens are on. Israel has indicated a code up there. Once you go to mentimeter.com, enter the number 86530132, and it will take you to the feedback poll. We need your feedback. Yes. Yeah. You. I cannot rest you. Money go there for madam to cook up banana. Did the conference meet your expectations? Did the conference meet your expectations? So go to mentimeter.com, enter the code. Don't worry, we have learned to take feedback positively. Perfect. We are followed by the senior team from PS Kenya. So quickly, senior team. I know we had different priorities. Do we have Ken already? Ken, Sylvia left. Gladys. Please, Monica, Dr. Kawiti. Please come. The team of Rotich, senior managers. Please, PS Kenya. Perfect. Sorry for flooding your ears with a lot of information. The Mentimeter polls are still going on the sides. We want your feedback. Question number 1, we are waiting to hit 30 responses, then we'll move to the next 30 as a minimum. Did the conference meet your expectations? Perfect. The rest of the PS Kenya team, for all the work you've done, you get a shot with the donor today and country directors. It is your chance. Okay, please come. Please read the code on the screen. Just read it as it is. Thank you. Committee, please move very quickly. We are on lunchtime, taking away time. Quickly, quickly. Desip Organizing Committee, the Learning Conference Organizing Committee. We had 23 responses for the first question. Aha, good. We are moving. I can see we are approaching 40, 50. Code 86350132. We're gunning for 50 responses, then we move. 50-50. Perfect. So as we move to the next question on the screens, the first one, yes, and thank you to the team that graciously agreed to pose for many photos. We take that as your consent. Thank you. So we are finalizing the second question. Were the sessions informative? You're allowed to give a narrative. We'll take that for only 60 seconds. I need someone to let me know when a minute passes.
I don't want you to the waste my time. I don't wanna wait till it's all over. This life is a gift from the most nature. That is why I'm thankful for all I have. Cause the fast life really ain't all that. So now I try to be pure. Don't be like scared this shit no man. I just get better in job. Waiting to see for this life plenty.
All right. So I'm waiting for 40. 40 is so fast. 27 and 40 are not so far. Let's keep going on the feedback. Thank you. Let's keep going. Perfect. Thank you. Let's keep going. Lunch is beckoning at us. Let's answer. Lunch is calling. Cake might leave. Cake might just walk away. 50 is approaching. Were the sessions informative? What did you like? What can we take away? 50. Who's the last 7 people to give us feedback? Let me close it at 45. Perfect. Say a third question. What areas did PS Kenya do well? A 60-second cue for me, Commander. Quickly, 60-second. What do you think we did very well? The code is up there. Again, 50-50 is the take. Or 40, or 1 minute, whichever comes first. PS Kenya, please don't participate in giving yourself feedback. All right. They're coming in, going for 20 more responses. We're almost done. This is the second last, and then the last, and we're done. Good. They're coming in. Live responses, anonymous. We're going for 40 responses. Let's keep them going. Perfect. Okay. So we have sustainable approaches, CBD, religious leaders engagement, CBD, involvement of all stakeholders, social inclusion, panel discussions, program delivery, let's see them. Learning conference, county engagements, sustainable approaches, yes, did very well. I'm looking for just 30, then we can move. I like the likes, they're just flowing. Okay. So the next part is the most important part of the feedback. This is the one we need to grow. I talked about measuring, designing, doing better. So this is it. Let's move to the final one. Where can we do? You're afraid of areas of improvement. All right, so on your device, the last question is around what can we do better? What should we have done better? What can we do better? Yes. Moving to the next one. Yes, what can we improve on from this conference? This is the most critical. So we're looking for 70 responses if possible. Coming in. Feedback is a gift for our final prayer. And then we more time. We can improve. We are experts. So let's have the feedback. Regular such kind of